All right. So good morning, everyone. Welcome to Health Coverage Insurance and Financial Services. Oh, my goodness. Don't make me use the gavel. Good morning. I don't usually break out the gavel, but everyone seems a little rambunctious this morning. This morning, we have two public hearings on some rules. And before we get started, we'll do introductions, starting with Representative Mastracchio.
Good morning. I'm Anne Marie Mastracchio. I represent House District 142, which is part of the city of Sanford and the village of Springvale. Forgot where I was from.
Good morning. I'm Representative Joshua Morris, represent House District 91, which is Turner, Leeds, and Wayne, where the only creature that seemed to enjoy the freshly fallen snow this morning was my dog.
Good morning, everybody. Paul Flynn, House District 63, which is Winslow, Albion, Freedom, and Unity Plantation.
Good morning, Rolf Olson, District 86, which is Raymond, Casco, Fry Island, and part of Poland.
Good morning, I'm Bob Foley. I represent House District 145, which is most of the town of Wells.
Good morning, everybody. Thank you for joining us. I am Representative Poppy Arford. I represent State House District 101, the western part of Brunswick.
Good morning, Michelle Boyer, represent House District 123, which is most of Cape Elizabeth.
Good morning, I'm Sally Clucci. I represent House District 52, which includes the communities of Bowdoin, Bowdenham, and Richmond.
Good morning. My name is Christy Matheson. I represent District 151 in Kittery, and I serve as the co-chair, and I would love to see some videos of that dog, Rhett Morris.
And I am Senator Donna Bailey. I represent Senate District 31, which is Buxton, Old Orchard Beach, and Saco, and I serve as the Senate co-chair. So our first public hearing is LD 2167. Resolve regarding legislative review of portions of Chapter 100 enforcement procedure, a major substantive rule of the Maine Health Data Organization. And I believe we have Ms. Harrington on Zoom. Right.
Very much this year.
Good morning, Ms. Harrington, whenever you're ready.
Good morning, Senator Bailey, Representative Matheson, and members of the committee. My name is Karen Lee Harrington, and I'm the Executive Director of the Maine Health Data Organization and Maine Quality Forum. And I am here today to present testimony in favor of LD 2167. I'm going to quickly run through my testimony. The purpose of the MHDO, as you know, is defined in Title 22, Chapter 1683, and we are required to create and maintain a comprehensive, useful, objective, reliable healthcare information database that is accessed by a broad group of authorized users to improve the healthcare quality and cost for Maine people, and to promote the transparency of the cost and quality of healthcare services, including prescription drugs in the state through many annual mandated reports. The MHDO is convened by a board of directors. It's a multi-stakeholder group, and the representatives are from payers, hospitals, providers, consumers, employers, and government. And our governing statute includes provisions regarding fines and enforcement actions for when a person or entity violates the requirements of Title 22, Chapter 1683. Our rule that governs those enforcement procedures is Chapter 100, and it establishes the schedule of fines and other enforcement actions for failure to file specific healthcare data, failure to pay the annual assessment, and intentional or knowing failure to protect the disclosure of confidential or privileged data. The MHDO Board of Directors met. They held a public hearing on September 4th of 2025 on the proposed changes to Chapter 100 that are before you. There were no public comments that were received at the public hearing or by the 10-day public comment deadline of September 15th. The MHDO board then met on December 4th and unanimously voted to provisionally adopt the rule as proposed and presented to you today. The substantive proposed changes that have been made are necessary to align the enforcement requirements in both Public Law 2023, Chapter 584, and my testimony provides you what that LD number was, and 9590, Chapter 841, which is a rule that the MHDO board recently adopted. It's a routine technical rule, so it did not need to come before you. And it's the rule that governs the uniform reporting system for hospitals' price transparency requirements, which again was part of Public Law 2023, Chapter 584 that I referenced above. The rule now includes, so Chapter 100, what's before you, now includes under Section 3, which is the section of the rule that's penalties and fines. It includes a provision that hospitals need to file their price transparency data and or meet the standards for data as defined in 9590, Chapter 841. And you'll see there are two attachments to my testimony, and one is the basis statement that summarize all of this, and the other is an actual copy of the rule with the track changes in it. So if you're looking for the specific changes in Section 3, you want to look at page 11, and there's a new M. And that new M is the requirement that's described here in the basis statement. The Attorney General's office signed off on the form and legality of the proposed changes under the Maine Administrative Procedures Act. And there's one other change. It's not substantive, but I do want to bring it to your attention. And it's in the definitions section, which I believe in your copy is page 7. It's in the definition of hospital. And we just made a minor update to that definition to align with all of our other rules. We crossed out this reference to acute care and put in any type of hospital, which again aligns with what we're doing in all of our other rules. So with that, I'd be happy to answer any questions now or at your work session.
Okay, great, thank you. Questions from committee members? Representative Arford.
Thank you, Madam Chair, and thank you so much. It's so good to see you again, Ms. Harrington. Thank you so much for being with us today. And I just want a little bit of level setting. Is this directly in response to or related to the price transparency bill that we passed 2 years ago and the requirements that was set forth in that? Is this connected to that?
Yes, I believe so. So this is as a result of LD 1740,
Okay.
an act to protect a patient's access to affordability healthcare with timely access to healthcare prices.
Mhm.
And in that bill, there was a Part B.
Yeah.
And Part B is what MHDO is required to comply with, which requires that we enforce the federal hospital price transparency requirements that are in the federal rules. And so the board, we've been looking at that data and working with that data for about a year or so, maybe over a year now. And just recently, the MHDO board adopted a formal rule that governs now that requirement. And so now we were ready to put it into the enforcement rule, and that's why I'm here today.
Well, I just really want to thank you for the work you've done on this. As you know, that was my bill. I'm a huge price transparency. I believe in it. I believe it's in everybody's best interest. So thank you so much for bringing this to us today.
Further questions? Seeing none, thank you for joining us.
Thank you.
Anyone else wishing to testify in favor of this bill? Anyone wishing to testify in opposition? Anyone wishing to testify neither for nor against this bill? Any requests from Colleen for clarification? session. We can, if you'd like to make that motion.
I'd like to make a motion to suspend the rules and go into work session.
Seconded by Representative Arford. All those in favor? That is unanimous. So we're now in work session and someone would like to make a motion? Representative Clucci,
Thank you, Madam Chair. I make a motion ought to pass.
seconded by Representative Foley. And that is the right motion, right, Colleen?
It is.
I always get confused with the rules.
If you don't want to approve it, it has to be ought to pass as amended, and amend it to say you don't approve it, but if you approve it, it's just straight ought to pass.
Great.
Yeah, I knew that, and that's why I made that motion.
You're good.
You're better than me, because I always forget.
Yeah. And they are an emergency, so.
Yeah.
So it does need a 2/3 vote, just so you know.
Okay, great. All right, so the motion is ought to pass. Any discussion? Seeing Representative Arford.
Thank you, Madam Chair. My comment is that this is a very common sense progression of both the work that's been done at the federal and state level over the last 4 years around price transparency. And this really is going to put teeth in the bill that we have passed and the bill that's done at the federal level. So like I said before, I'm very appreciative of Ms. Harrington for bringing it to us and the work we're doing on it right now.
Thank you. Further discussion? Seeing none. Edna, do you want to call a roll?
Thank you. Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Alford.
Yes.
Representative Alford, yes. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Clucci.
Yes.
Representative Clucci, yes. Representative Flynn.
Yeah.
Yes. Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Olson.
Yes.
Representative Olson, yes. 10 members of the committee have voted in the affirmative and 0 in the negative.
Thank you. So that will close the work session on LD 2167. And we will open the public hearing on LD 2166, resolve regarding legislative review of Chapter 6, delegation of nursing activities and tasks to unlicensed assistive personnel by registered professional nurses, a major substantive rule of the Department of Professional and Financial Regulation, State Board of Nursing. I'm not sure if anyone is presenting this. Yeah. Please come forward. Put your name on it.
I do say that. My name on a lot of things.
Who knows that?
Lesson learned.
Good
Morning.
morning. Whenever you're
Okay,
ready.
all right. Senator Bailey, Representative Matheson, and members of the committee. My name is Kim Escabel. I'm the Executive Director of the Maine State Board of Nursing. I've also been a nurse for over 40 years.
Wow.
It's hard to say that sometimes. I'm pleased to offer the following comments in support of LD 2166. As you know, on April 30th, 2025, Resolve 2025, Chapter 21 did not authorize the board's final adoption of the prior version of the rule. We sincerely appreciate the comments and stakeholder feedback so that we could move forward. So since then, the board has engaged in an extensive consensus-based rulemaking process with stakeholders. We revised the rule in response to the committee and stakeholder feedback. We published the reproposed rule for public comment, held a public hearing in November of 2025, and the Board of Nursing provisionally adopted the reproposed rule in December of 2025. So the provisionally adopted rule before you directly addresses the concerns raised by the committee regarding task clarity, nurse responsibility, nurse liability, and protection against coercion. Specifically, the revisions include the following. And in your packet, I have highlighted, I'll refer to those. So on page 1, section 1, we added an entire purpose section, which includes that delegation is permitted, it's not required, nor can it be coerced. Page 2, paragraph 1, we added a clarifying statement that the scope of delegation and the level of supervision may vary upon type of setting and the patient's condition. Section 2 on page 2, under definitions, we included a definition of activities of daily living. These are basically the types of supportive activities and tasks that UAPs would be providing. And then on page 3, section 3(1)(a), we included language regarding the liability of the nurse. So in the event the qualified unlicensed assistive personnel deviates from the instruction, care plan, or other delegating nurse directive, the delegating nurse does not bear responsibility and accountability for the outcome of the delegated activity. Page 3, section 3(1)(e) includes language that employer policy or contractual language cannot mandate the licensed RN to delegate nor mandate any components of the delegation process. And then page 5, section 4, and page 6, section 5, we've included a section on nursing activities and tasks that are most commonly delegated. And these are basically supportive activities of daily living tasks. Ambulation, transportation, personal hygiene, things like that. So the board did maintain language allowing the delegating nurse to be readily available to the UAP, performing the delegated nursing activity or task either in person, by telephone, or through another form of telecommunication. The board thoughtfully reviewed and considered the committee's feedback on the use of telecommunication, and it determined that it should remain consistent with RN nurses delegating to LPNs, CNAs, and CNAMs. So currently there may be instances, depending on the setting, where an RN can delegate a task to an LPN, a CNA, and it can be through telecommunication. Evidence-based standards support that the delegating nurse does not always have to be physically on site when delegating, but they are required to be readily available for supervision, either in person or through telecommunication. And again, the RN uses clinical judgment to determine if the situation allows for delegation either in person, by telephone, or through another form of telecommunication, with the primary goal of ensuring patient safety. The level of supervision required depends on the stability of the patient, the setting, the complexity of the task, and the demonstrative ability of the UAP to perform the task. And you will hear testimony today on specific examples of that. And in addition, I just want to mention the Chapter 11 joint rule regarding telehealth standards of practice. If a RN delegates to an unlicensed personnel, they have to ensure that systems are in place to ensure that the UAP are qualified, trained, and authorized to provide that service, and the licensee is available in person or electronically to consult with the UAP personnel. So the board believes it has thoughtfully addressed the concerns and recommendations of the committee, and we respectfully urge the committee to authorize final adoption of the rule. Thank you.
Thank you. Questions from committee members? Representative Matheson.
Yes.
Thank you very much for
Yes.
their hard work.
Thank you.
I just wanted to clarify in chapter 11, when number 1, you say systems are in place. What does that mean? To ensure that a non-clinician healthcare professional are qualified and trained. How do they do that? What does that mean?
So it could be a home care agency. The UAP may be employed by that home care agency, and the RN can determine that they are competent based on competency demonstration and forms that are on file.
Thank you.
Okay, further questions? Representative Harper.
Thank you, Madam Chair. I just really want to thank you for this chart. That is so helpful in understanding what we're actually talking about, at least part of it. And I just really wanted to express my
Thank you.
appreciation. Thank you.
Thank you.
Okay, further questions? All right, thank you. And thank you for your hard work.
Thank you.
Anyone else wishing to testify in favor?
There. Good morning, Senator Bailey, Representative Matheson, and committee members. My name is Lisa Harvey McPherson. I'm a registered nurse. As the previous speaker noted, I too have been a registered nurse for over 40 years. I'm here today presenting testimony and support on behalf of the organization of Maine Nursing Leadership and Maine's Nursing Action Coalition. And as I noted in testimony in prior years, the language before you today in the rule is critically important because the law that you passed in 2024 removed antiquated language of coordination and oversight and modernized our nursing practice to allow for delegation to unlicensed assisted personnel. In 2019, the National Council of Boards of Nursing and the American Nurses Association published national guidelines regarding delegation, and that included delegation to unlicensed assisted personnel. After that joint white paper came out nationally, pretty much every state in the country amended their Nurse Practice Act to allow for delegation to unlicensed assisted personnel. Maine is one of the last states in the country to adopt the rule that's before you today. That white paper identified the 5 rights of delegation, which are in the proposed rule that's been presented to you. It's the right task, right circumstance, the right person, the right direction and communication, and the right supervision and evaluation. After the session ended last year, the Board of Nursing took back all of the feedback that they heard, and they redrafted the rule regarding delegation to unlicensed assisted personnel. And in the summer, they gathered all of the stakeholders, those who had testified for the bill and those who had testified against the rule, and heard all of the voices about the redraft. And it's a significant redraft that's been presented to you today. The board held a public hearing on that redrafted rule, and we testified in support, and the board provisionally adopted that redrafted rule in December. So this rule that you're considering clearly documents the responsibilities of the RN when delegating to unlicensed assisted personnel. And it also makes it clear that the nurse is in charge. The nurse can choose based on patient safety and clinical judgment to delegate, and the nurse can make a decision when it's not safe and choose not to delegate. And the rule also incorporates language from the law that was discussed quite a bit at the hearing we had with you last year, that nurses may not be required or coerced into delegating nursing tasks. There was discussion last year about the need to have a framework of tasks that the nurses can delegate and the tasks that aren't appropriate for delegation in the rule. And chapters 4 and 5 of this rule incorporate that recommendation. When we talked about this in 2024, there was very important conversation that the patient can have an unpaid caregiver. And that unpaid caregiver is not subject to RN delegation. And that was a lot of discussion around home and community-based services. The rule before you clearly excludes these unpaid caregivers from the definition of UAP. So that intent has been carried forward. So now it's been 2 years since the law was passed. And we ask for your support to vote in favor of the rule that's before you today, so that we in the nursing community can develop policies and procedures and implement this delegation practice in all healthcare settings in Maine. And with that, my time is up, and I welcome any questions that you have.
All right, thank you. Questions from committee members? Seeing none, thank you very much.
Okay, thank you.
Anyone else wishing to testify in favor?
Good morning, Senator Bailey, Representative Matheson, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Adam Good. I'm the Legislative and Political Director at the Maine AFL-CIO. We represent 40,000 working people in the state of Maine. We work to improve the lives and working conditions of our members and all working people. Last year, we testified in strong opposition to LD 90 to support the more than 4,000 registered nurses and healthcare professionals who are members of the Maine State Nurses Association. At that time, we were concerned that the resolve could undermine the role RNs play in protecting the life and health of patients. The labor movement believes in the dignity of work, and to that end, we respect the work of all healthcare workers who help nurses deliver safe care. Unlicensed assistive personnel are there to assist and support RNs and should not be caring for patients without the close oversight of an RN. This year, we asked the committee to approve the Board of Nursing's proposed rule with a few changes. We want to thank the members of this committee for recognizing that last year's version of the rule needed work, and to the Board of Nursing for all their work incorporating the feedback of the committee and working with us and other stakeholders to improve the rule. We strongly support the aspects of this bill that ensure nurses have the right to refuse unsafe delegation. The proposed rule now requires employer policies to acknowledge the RN has the final say on delegation. The rule also includes essential details on criteria for delegation and when delegation is appropriate. We understand that you'll be receiving detailed testimony from Maine State Nurses Association, National Nurses United, that details additional changes that protect patient safety and to avoid making nurses responsible for behavior they cannot effectively control. Like MSNA, we strongly recommend eliminating delegation by telephone. We believe that the board should limit delegation to unlicensed assistive personnel with employer-verified competence. There are some nuances and exceptions to this principle. In general, we believe an RN should not be responsible for the actions or errors of an unlicensed person being directed by a patient or family member. We would support the recommendations on this principle that you will find in the NNU testimony that I believe is going to come over Zoom later in this hearing. The proposed rule includes examples of delegable and non-delegable tasks. One improvement on these examples would be to include any task that requires certified nursing assistant training as not appropriate for delegation to an unlicensed person without that training. So we appreciate the work of this committee and the board in including our thoughts on the legislation to point, and those are some ideas we have. So I'm happy to answer any questions.
All right, thank you. Representative Clucci.
Thank you, Madam Chair. So it sounded like, so I'm curious why this feedback wasn't given earlier on in the process rather than now at the 11th hour.
That's a great question. I was not involved in the stakeholder process around improving the rule. I believe that Bryn O'Neill or one of her colleagues at MSNA, who's going to be testifying over Zoom shortly, will be able to answer that question.
Okay.
Further questions? Representative Mastracchio.
Thank you, Madam Chair. So in the last paragraph on the front page, you say that like MSNA, we would strongly recommend eliminating delegation by telephone and believe that the board should limit delegation to unlicensed assistive personnel with employer verified competence. But if I was a nurse and I knew that the person was competent, why couldn't I delegate something by phone? I mean, you're
Yeah.
saying, I mean, to me, that's the whole point. I have this issue. Can I do this? You're on your way in, you're not here yet. And this, it doesn't make sense to me. That's all, because I don't understand. They're not going to delegate to somebody that they don't think is competent. So
I understand what you're asking. I don't know exactly what Bryn is going to say when she tries to answer that question, but I suspect that the perspective might be that it's the responsibility of the employer to verify that, not the worker themselves. And so that might be my guess.
can I just ask follow up? Because the whole point of this was that they aren't going to be asked to delegate to somebody that they don't, or something that they don't want to delegate, or they don't think should be delegated. But that is also true that the person that they're going to delegate to, that they have confidence in that person. I don't think that makes a lot of sense, that particular issue. And I will just comment that there was a public hearing on these rules and nobody spoke against them.
Yeah.
I mean, that's all.
Thank you. Yep.
I'm not sure that was a question. Further questions?
Thank you.
Thank you. Anyone else in the room wishing to testify in favor?
Good morning. Senator Bailey, Representative Matheson, members of the committee. My name is Bill Monteo. I am the Director of the Division of Licensing within the Department of Health and Human Services. I am also a registered nurse. Unlike the two nurses that spoke before me, I am limited and I only have 22 years of nursing experience. So I'm still a new nurse.
Yeah, just a baby.
I am testifying in support of this bill. I will share with you that my colleague from the Office of Aging and Disability Services had intended to be here to testify in strong support of this bill as well, but she was unable to, so you will receive her testimony in written form. She was also one of the stakeholders involved in this bill, in the rules, excuse me. The department worked with the Board of Nursing and stakeholders in the development of the rule and believes that the decision regarding delegation to unlicensed personnel should be determined by the registered nurse's professional judgment based on the patient's condition, the amount of supervision by an RN needed, and the knowledge and competency of the unlicensed staff. The rule outlines the responsibilities of the registered nurse to ensure the delegation is appropriate and consistent with national guidelines adopted by the National Council of State Boards of Nursing and the American Nurses Association. The rule also clearly articulates that the nurse can rescind the delegated practice based on professional judgment should conditions change and such delegation is no longer appropriate. The department strongly supports this rule as an important mechanism to improve the health of residents and the quality of care and quality of life in non-nursing facilities and home-based settings. And I will share with you a real-life example that we had to address within our office. Several years ago, a resident residing in a non-nursing residential facility up in Aroostook County had been discharged from a hospital back to home. The home health agency was unable to provide care and services. This individual needed a subcutaneous Lovenox injection for a period of, I believe, 6 days. The physician had made arrangement for a pre-filled auto injector. There was no figuring out the dosage. It was automatically pre-filled But because there was no ability for the nurse to delegate, the individual had to be transported 25 miles one way to the physician's office to get that injection. This would allow the nurse, because the nurses are really advocates for the patient and looking at for the patient's well-being, to determine if they had qualified, competent individuals that could do this with a pre-filled auto injector, and would be operating in the patient's best interest. And I will, my experience, I had a colleague back in my days as a paramedic who had started as a CNA, became a paramedic, worked as a CRMA in a nursing home in Cumberland County. That individual, who was technically an unlicensed person working in a facility, would be appropriate to delegate some of these things to based on the nurse's judgment and knowledge of that individual, versus somebody who just graduated from a course 2 days prior may not be fully competent to do this. And that's why I think there really needs to be some professional judgment of the nurse to ensure that the individual that they are looking to delegate this to is competent to do what they and understands the practice. I understand the previous speaker's, preference for the employer, but for me as a nurse, the employer hires somebody who is a certified residential medication aide, for example. They've passed a course with some minimum competencies. I still want to evaluate that individual and make sure they fully understand the task that I'm asking them to do and that they're competent to do it. This is not a blanket delegation to a facility or an agency for all staff. It is individual-based, it is patient-based and patient-specific. And I think this will go a long way to helping improving quality of care and quality of life for people that are residing in facilities that do not have nurses. Happy to take any questions.
Thank you. Questions from committee members? Seeing none, thank you very much. Anyone else in the room wishing to testify in favor?
Senator Bailey, Representative Matheson, and members of the committee. My name is Mikkel Neal. I'm obviously a registered nurse. This is my 26th year. I'm the Associate Vice President of Nursing Services at Northern Light Eastern Maine Medical Center in Bangor. I'm speaking today on behalf of all of Northern Light Health and all of our member organizations in support of this bill. As you've heard, Maine is one of the few remaining states to establish rules defining RN delegation to unlicensed assisted personnel, or UAPs. Given the tremendous changes occurring in healthcare, the proposed rule we feel is vitally important. The law regarding coordination and oversight of unlicensed assisted personnel is no longer in effect, and the 2024 law regarding RN delegation to UAPs must be supported by rules that reflect modern practice of professional nursing delegation to ensure safe, quality nursing care for patients throughout the entire state of Maine. Registered nurses have many responsibilities. Nursing shortages, technological advances, increasing complexity in patient care, and continuous changes in healthcare in all care settings have made delegation in nursing really essential. In the acute care setting, nurse delegation to unlicensed assisted personnel will improve patient care by allowing UAPs to perform competency-based tasks, allowing the RN to utilize this information to support their nursing judgment and their patient assessment. Nursing professionals and patients in our care benefit when the RN role is focused on critical thinking to guide their patient care. In 2019, the National Council of State Boards of Nursing and the American Nurses Association published joint guidelines on nursing delegation. The guidelines can be applied to RNs when delegating to UAPs. The guidelines establish professional nursing standards regarding delegation, the 5 rights of delegation that are reflected in the proposed rule, which you heard are the right task, right circumstance, right person, right direction and communication, and right supervision and evaluation. The proposed rule also reflects unique aspects of Maine's delegation law in that nurses cannot be required or coerced to delegate tasks to UAPs. The rule also includes examples of tasks that are appropriate for delegation to UAPs and those tasks that may not be delegated. This will assist nurses in incorporating the delegation rule into their professional practice. The proposed rule has the necessary elements of effective regulatory policy. The definitions are clear and comprehensive for the purpose of the rule, and the responsibilities of the nurse align with national principles of delegation. The language of the rule provides registered nurses with an understandable and enforceable framework of responsibilities when delegating those nursing tasks or activities in our patient care settings. We ask that you support this important legislation so that the Maine State Board of Nursing can formally adopt the delegation rule. We look forward to creating nursing care policies and procedures to operationalize delegation of nursing activities to UAPs in all of our Northern Light healthcare settings. Thank you.
Thank you. Questions from committee members? Seeing none, thank you
Okay,
very
thank you.
much. Anyone else in the room wishing to testify in favor? Welcome.
Good morning.
Good morning.
I don't have written testimony. No. Good morning. Senator Bailey, Representative Matheson, esteemed members of the Joint Committee on Health Coverage, Insurance, and Financial Services. My name is Marge Kilkelly, and I am testifying today on behalf of Legal Services for Maine Elders in support of LD 2166. We provide legal services across the state to folks over 60. Many of them have complex medical needs, and obviously they are low income. Last year, Legal Services had concerns about this bill and the fact that the rules and that they were not clear enough and not outlined. And we are very pleased with the proposal that is before you today and very much support it. It does, as previous speakers have said, it's very clear about what tasks can be delegated, what can't, what the requirements are, and we feel very comfortable with it. So thank you, and we urge your support.
All right, thank you. Questions from committee members? Seeing none, thank you. Anyone else in the room wishing to testify in favor?
Good morning, Senator Bailey, Representative Matheson, and the members of the committee. My name's Nicole Chadwick, and I'm providing testimony in support of this bill on behalf of Northern Light Health and our member organizations. And I'm here kind of to give the rural side of the puzzle here. I serve as the Vice President of Education and Preparedness for 3 Northern Light Health hospitals, Northern Light Mayo Hospital, C.A. Dean Hospital, and Sebasticook Valley Hospital, all critical access hospitals. I'm a registered nurse with 31 years of experience working in Maine and always in rural hospitals. Rural hospitals, along with all rural healthcare settings, are under significant pressure and unprecedented time in this era. Hospitals are closing, clinical staff is challenging, and the financial difficulties we experience caring for this population will continue in the foreseeable future. Nurses must be allowed to practice to the full extent of their knowledge, skills, and delegation to unassisted or unlicensed assistive personnel, and that's a definite component of our professional practice. In my role as a nurse educator, I teach nurses, CNAs, medical assistants. One of my roles to teaching nursing is about delegation and how to do it safely and how to do it well. I teach them about delegation and the RN responsibility for safe patient care. Northern Light C.A. Dean Hospital is one of the smallest hospitals in Maine with only 15 beds in our facility. Given the small number of beds, we also have a small number of nurses that care for those patients. Delegation of tasks to unlicensed assistive personnel will allow us to care for patients as a team with nursing judgment being our guide. Clinical decision-making leading the way for safe care for everyone. At Northern Light Mayo Hospital, our patient safety technicians, who are UAPs, stay with patients who are at risk for falling. They are one-to-one with those patients, meaning one tech to one patient. Since the Board of Nursing has not been able to formally adopt the RN delegation to UAP rules, the technicians are not allowed to assist the patient with personal care. So they have to call the nurse or the CNA to get assistance to help the patient eat. Each and every time the technician must call and the nursing staff are pulled away from other tasks due to regulatory barriers. These staff can perform these delegated tasks safely. We need your support to approve this bill and to allow us to delegate based on our judgment to provide safe care. A lot of times these UAPs are nursing students or CNA students that are already in a class. So they're already getting advanced training, and we actually have to hold them back to doing some of the tasks they know how to do. Your support of this bill provides nurses like me in rural communities, along with nurses throughout the state of Maine, with personnel support to care for our patients in a safe and professional and appropriate manner. Thank you.
Thank you. Questions from committee members? Representative Mastracchio.
Thank you, Madam Chair. So if I was visiting my husband in the hospital and he needed help getting into the bathroom or, I could do that. I mean, nobody's going to stop me, right? But in this hospital, I mean, let's face it, if there's nobody around, I've done it, If you can, they'll say, no, don't call the nurse, don't call the person. So in the small hospital right now, they literally have to call the nurse, even if they're there with a one-to-one.
Yes.
And they still have to call the nurse.
Yes, because that's not within their role.
Further questions? Yeah, Representative Matheson.
Thank you for your testimony. It's really helpful. I just wanted to know, what is the education around delegation that you teach the nurses? What does that encompass?
So it goes over those same basis delegations that have been brought up a couple of times. So, making sure it's the right task, the right individual, the right education, and the right setting. And a lot of times we give the nurses scenarios. So you have these things to do. Which ones can you safely delegate to those patients? So we use a lot of scenarios and role playing to kind of make sure they know what those safe rules are and what things are they're going to assure before they make sure they delegate those tasks.
So is that like an hour-long course? Is that a 7-month course? I'm just curious for context.
And the funny thing is, it's all throughout I'm working with associate degree nurses, so 2-year program, but we deal with delegation as they progress through their program. So it's not just a one and done education. It's pretty much throughout the program that they get there, and they get into more complex situations as they get towards graduation.
Thank you. Further questions? Seeing none, let me just say, with all these nurses and so many years of experience, I'm feeling particularly safe. Just want to throw that out there. Thank you. Yeah. If you need to have a medical emergency, now is the time. Anyone else in the room wishing to testify in favor? All right, we do have some people online. And if you want to move Jill over. Good morning.
Good morning.
Whenever you're ready.
Thank you so much. Senator Bailey, Senate Chair, Representative Matheson, and honorable members of the Joint Standing Committee on Health Coverage Insurance and Financial Services. My name is Jill Vaughn. I am a nurse practitioner, and I am the president of the American Nurses Association of Maine, and I am here to support LD 2166. I won't take up much of your time because everything in my testimony that has been submitted has already been covered by the wonderful nurses and healthcare providers that spoke before me. And I just wanted to attest that this has been a collaborative process of stakeholders, and I very much appreciate the work that went into crafting Chapter 6. And I also want to thank our legislators for their time and consideration in supporting not only the nursing profession, but safe patient care. Thank you very much.
All right, thank you. Questions from committee members? Seeing none, thank you for joining us. And if you want to move over, Malia?
Hi, good morning. My name is Tith Malaya Lewis. I'm a nursing director at Maine Health Maine Medical Center in Biddeford and Sanford. Hello to Senator Bailey, Representative Matheson, and members of the Committee on Health. I, like many of my nursing colleagues before me, am here to testify in support of LD 2166. So thank you for the opportunity. Delegation is not about handing off responsibility. It is about using the full healthcare team appropriately while nurses remain accountable for patient outcomes. The proposed rule provides clear guidance for how nurses assess patient stability, verify unlicensed assistive personnel, the competency, communication, expectations, and supervising delegated tasks, and stepping back in when a patient's condition changes. These are the safeguards nurses rely on every day, and having them clearly defined in the rule protects both patients and the workforce. From a practical standpoint, these rules make nursing work more efficient and less fragmented. Clear delegation standards reduce time spent clarifying scope, second-guessing decisions, or correcting misunderstandings. Nurses can confidently delegate appropriate routine tasks and focus their expertise where it's most needed, using their clinical assessment, patient education, coordination of care, and early recognition of deterioration. This clarity also improves teamwork, and teamwork is big amongst the healthcare team. Nursing assistants consistently report that knowing exactly what is expected of them, when to escalate concerns, and how supervision works makes them feel more supported and engaged. Chapter 6 creates a shared framework so everyone is working from the same understanding. Most importantly, this rule improves patient care. When RNs are able to delegate safely and appropriately, they have more time to spend with patients who are stable, complex, or at higher risk. This supports better monitoring, faster intervention, and stronger communication with patients and families. Chapter 6 supports patient safety by ensuring delegation is intentional, structured, and grounded in professional judgment, helping us protect patients while also supporting nurse retention. If LD 2166 were to pass, RNs would be able to delegate assisted feeding to trained UAPs for patients who are stable and have no identified swallowing risks. When UAPs are properly trained and supported, they can help patients who simply need assistance setting up their meal, queuing, or basic hand-over-hand support. The RN also remains responsible for assessing the patient's condition, monitoring for choking or aspiration risk, and evaluating nutritional needs. Allowing UAPs to assist with feeding in appropriate situations not only enhances patient dignity and mealtime support, but it also frees the RN to focus on higher acuity needs, improving both workflow and patient care. This is a thoughtful and compassionate use of the care team that many organizations rely on with clear delegation standards. Maine nurses could benefit from the same safe, team-based approach, and Chapter 6 supports this common effective practice by outlining roles, responsibilities, and accountability. This benefits both patients and the care team. I respectfully urge you to support LD 2166 and the final adoption of Chapter 6. Thank you for your time, your consideration, and your continued commitment to the health of Maine people.
Thank you. Questions from committee members? Seeing none, thank you very much for joining us.
Thank you.
And if you want to move over, Sarah. Good morning, whenever you're ready.
Thank you. Good morning. Chair Bailey, Chair Matheson, and members of the committee. My name is Sarah Ratcliffe, and I serve as Executive Director of the Maine Alliance for Care at Home, formerly the Home Care and Hospice Alliance of Maine. The Alliance is submitting testimony in support of LD 2166. The Maine Alliance for Care at Home is a network of home care, hospice, and personal care providers across our state at delivering in-home care to older adults and disabled individuals of all ages, allowing them to stay in their homes and communities. The Alliance is strongly in support of LD 2166, allowing RNs the option to delegate appropriate tasks to unlicensed assistive personnel is a critical step towards strengthening Maine's care delivery system, particularly in the home care and hospice settings, where workforce challenges and rising patient needs continue to intensify. Importantly, this resolve does not mandate delegation. Rather, it provides RNs with a flexible, clinically sound tool they may use at their discretion. Delegation remains firmly grounded in the nurse's professional judgment. The RN retains full authority to determine whether a task is appropriate to delegate, to oversee the delegated activity, and to modify or revoke that delegation at any time based on the patient's condition, the competence of the UAP, or other relevant factors. Additionally, home health and hospice agencies increasingly rely on remote technology to support RN supervision, enabling timely communication, real-time documentation, and efficient oversight of delegated tasks. Employees of home health and home hospice are by definition in remote locales. It's technology, including telephony, that ensures safe and efficient patient care and is essential to our practice. These tools enhance care coordination while preserving the RN's clinical authority and accountability. The Alliance also supports a patient's right to hire their own personnel, including nursing students, and agrees with nurse delegation to these individuals when appropriate. The flexibility respects patient choice while ensuring that all delegated care remains under the supervision and professional judgment of a registered nurse. For home care in particular, the ability to safely delegate tasks to trained UAPs is essential. Maine continues to face a significant nursing shortage, especially in rural and underserved areas. Many patients who wish to remain at home struggle to receive timely services simply because a registered nurse is not available to complete every task personally. Delegation, when appropriate, can expand capacity, support continuity of care, and allow more Mainers to receive high-quality services in the setting they prefer, their home. Thank you for your consideration and for your ongoing commitment to advancing safe, high-quality nursing care in Maine. We appreciate the opportunity to testify and stand ready to support the successful implementation of this important law.
Okay, thank you. Questions from committee members? Seeing none, thank you for joining us this morning. And that is all I have for in favor. No one snuck in. Is there anyone wishing to testify in opposition? Anyone wishing to testify neither for nor against? All right, we do have one person online who signed up, neither for nor against. If you want to move Bryn over, please. Good morning.
Good morning, Chair, members of the committee. I'm Bryn O'Neill. I'm speaking on behalf of the Maine State Nurses Association / National Nurses United, a union representing more than 4,000 registered nurses and healthcare professionals providing direct patient care in our state. And we're asking the committee to approve the Board of Nurses' proposed rule, just with a few changes. Everything I'm going to say is in written comments, which you should already have, including, text edits for these changes. And we've submitted all of this throughout the stakeholder process, starting with the stakeholder meeting, I think over the summer, well, starting with this committee last year, really, or the process before that. Anyway, getting lost. And a letter in there's a letter from the formal rulemaking process that I attached to my written comments. So MSA really wants to thank the members of this committee for your serious attention to your oversight duties and for recognizing that last year's version of this rule needed some work. And we want to thank the Board of Nursing for all their work incorporating the feedback of the committee and working with us and other stakeholders to improve the rule. Among the improvements in this rule, there's language that helps nurses stand up for their right to refuse unsafe delegation. The proposed rule now requires employer policies acknowledge that the RN has the final say on delegation, and it includes essential details and criteria for delegation and when delegation is appropriate. However, as we've raised throughout the process, there are a few additional changes we'd like to see to protect patient safety and to avoid really making nurses responsible for behavior they cannot effectively control. So first of all, MNSA does strongly recommend eliminating delegation by telephone. Before delegating, an RN must conduct a thorough nursing assessment, and this assessment can really only be safely completed in person. And an RN also needs to be in the same physical location to be able to effectively supervise and intervene if the patient's condition deteriorates or if the task is done improperly. With the increasing complexity of care that's being done in the home, in other states, we've seen remote delegation expand far beyond what can include any effective supervision. So we're concerned about the potential there. Second, the committee should require that the board limit delegation to situations where there's an unlicensed assistive personnel with employer verified competence. So the employer should be responsible for establishing written policies and procedures for unlicensed personnel based on practice setting and within the parameters of the board rule. And then the RN considers factors such as when a patient is sufficiently stable to allow for responsible delegation. So employer verification of competence does not substitute for that of a nurse. The nurse makes the decision on every delegated task, but we also have to recognize that a nurse does not generally have the power to select what personnel are available or what training they had. So it's important to have those two layers there. So in most cases, this proposed rule appropriately establishes that it's the responsibility of the employer to ensure that assist UAP receive training and are competent to the tasks within their job descriptions. But there are two exceptions to this general principle in the proposed rule. First, the proposed rule makes RNs responsible for ensuring the competence of UAP who are not employed by a facility or organization. And for safe delegation, the nurse must have access to the documented competencies and skills of the unlicensed personnel and to ensure that they both have a shared understanding of policies and procedures governing this care. And secondly, the definition of unlicensed assistive personnel excludes individuals performing tasks at the direction of a patient only if that individual is unpaid. And that exception should be removed. So the rule should prohibit RNs from delegating tasks to UAP being directed by a patient, whether they are paid or not. And that's all because an RN should not be responsible under their license for the actions or errors of an unlicensed person being directed by a patient or family member. Finally, MNSA really appreciates that the proposed rule includes examples of delegable and non-delegable tasks. To further improve those lists, we suggest including tasks that require certified nursing assistant training on the not appropriate for unlicensed people who don't have that training list. And we pulled those from another board rule, and that's in our written comments. So their written testimony includes appendices on how these changes could be integrated into the text of the rule. We really, again, deeply appreciate the committee's intervention to improve this rule and all of the Board of Nursing's subsequent work. And we really hope that you can move forward with this rule during this session with the changes we have outlined. Thank you.
Thank you. Questions from committee members? Representative Mastracchio.
Thank you, Madam Chair. So Ms. O'Neill, you were not one of the people that testified when they had the open time to, the period between October 17th and then the public hearing was heard on November 6th?
Yes, we submitted. Oh, sorry.
Let me just finish because it said they received verbal and written comments and there was no testimony in opposition or neither for nor against.
We participated, I know we participated in a stakeholder meeting in the fall, and then there's a letter attached to my written comments in the formal process. Everyone has heard these comments before. I'd have to check on that particular.
Well, I'm just asking if you participated in the point when because they really made no substantive changes after that. So
yes, so
that
we
was the
participated.
opportunity. That was your opportunity. I'm just wondering if you didn't. I'm questioning if you did participate. I'm not going to assume that you didn't. I'm asking you directly.
I don't remember that if we participated in that particular window. I know we've submitted these concerns multiple times.
Thank you.
Okay, further questions? Yeah, Representative Foley.
Yeah, thank you I don't have your testimony. Did you send that in to the committee?
I submitted it through the online portal, I believe, and if that did not come through, then I will be in touch with your staff to make sure you can get that.
Please do, because we do not have that here.
Okay.
Indications are it has not come through, so you might want to follow up on that.
So technical issues.
It is online, but
Oh.
you may not have had a chance to copy it.
Okay, so now I'm being told it is online, but it hasn't been copied yet, so we should be able to access that. Thank you. Further questions? Seeing none, thank you for joining us.
Thank you.
And there's no one else signed up on Zoom, correct? All right. Anyone else in the room wishing to testify on this bill? Any requests for Colleen for the work session? Seeing none, I'll close the public hearing on LD 2166. So we are now on break. We'll be coming back for work sessions starting at 1 o'clock. I know Democrats, we are going to caucus during that time as well. I think that's Okay. So good afternoon, everyone. Welcome back to the Health Coverage Insurance and Financial Services Committee. This afternoon, we have a number of work sessions. We have some language review and the only, I don't care if they're listening to me. The only request we've had to take things out of order is we would be taking perhaps LD 1220 as our last work session in order to allow one of the needed participants to be here. So with that, we will open the work session on LD 2056 and act to provide additional financing options to consumers in the state.
Edna, do you have the amendment? Did you give it to Edna? Oh, okay. Did you already pass it out? I think there's an amendment for LD 2056.
We don't see it.
Oh, okay. That's helpful.
Oh, there we go.
Coming around. Um, Thank you. So I think it probably makes sense to skip the analysis, but because my understanding is that the parties that brought the bill forward have been meeting with the Bureau of Consumer Credit Protection and have reached an agreement on the proposed amendment that Edna is distributing to you for your review. My understanding is they have reached consensus, and this amendment would clarify that the exception from the provisions, and I need one myself. I'm just doing it from memory, but the exception would apply only to the financing of new automobiles, and it would reduce the span, the 50% number in paragraph C to 36%, I think, if I remember right.
Yes.
So it clarifies that exception. And as I said, my understanding is that there's been an agreement that this language is acceptable to the Bureau and to the proponents of the bill.
Okay, thank you. Discussion, Representative Foley.
I just have a question. Have we defined what a new automobile is? I mean, I'm just curious because you can have a leftover and you can have a brand new. So what constitutes a new automobile? That's, I don't mean to throw a monkey wrench into it, but
No. So Ms. Conti, if you want to come up and see if you have thoughts on that? Or if you thought of it, or.
There is no definition. I think what I was trying to accomplish was that it wouldn't apply to used automobiles and it wouldn't apply to motor vehicles, which is a definition that could sweep in all kinds of things. So it was meant to be a narrow definition to a new car. So that the idea that there can be more than one definition to what is a new car, I would have to defer to Ford on that. Maybe they have a definition of it.
Yeah, except I would say, I mean, this isn't only going to apply to Ford, but
Yeah.
Representative Foley.
I just want to, maybe then we put in, it does not apply to used automobiles rather than to new automobiles. So I think we know what used automobiles are. But
I mean, I think you have the same dilemma though, is a leftover, or what do they call them? Dealer car, you know, that they use. And so maybe they have like 2,500 miles on it. Is that a new car or a used car? I don't know.
I know, I mean, I just raised the issue because
So do we, I don't know. Maybe we talk about
definition.
a mileage thing, but I don't know. Representative Colson. Sorry.
All you
no,
do-
I'm just,
all you
It's a
do
work
is
session. We're
simply
having a
say
discussion.
it makes
that it's
sense.
a not previously titled vehicle.
There's a lot of people in hand.
Thank you.
That solves it, because if it's been previously titled, then it's a used car. If it's not been previously titled, then it's a new car.
Representative Olson, could you repeat it? Because Edna was
Oh, okay.
talking to us and I wasn't.
What I'm saying is you just change that to say, not previously titled vehicle.
So when it's with the dealership, they don't have a title.
They don't.
I think that works.
Yeah, that's one,
And again, I
that's
don't
one
mean to
approach.
be
Yeah.
Difficult, but I just think you need to We just need to have a clarification. So I think that works.
Well, and again, I think we want to say the automobile based on what Linda
Oh, yeah.
said, not vehicle. We don't want.
Yeah.
Yeah. You all understood what I meant. I love it.
Yes.
I love my committee. Sometimes.
Yeah.
Representative Boyer.
Thank you, Madam Chair. Is it not defined somewhere else, I'm guessing, in statute at all?
Well, automobile is, but not new automobile.
Okay.
I mean, that's the issue.
It is in the lemon law, I think,
Yeah.
but it's a different definition than the one. There are,
Yeah. I mean, we could certainly, I think the suggestion about previously titled, addresses it probably the most, in the most
And I think that's.
clear way, and
And
that's
I
the
think that's
intent.
the intention
Right.
as well. So yes,
Right.
that was a good idea. Thank you.
so we'll be back for another language review.
Well, at some point, yeah.
All right, any more questions from Ms. Conti while she's up there? All right, thank you, thank you. Representative Cucci.
I was just wondering, so this is for anybody on the committee, is the rationale for limiting it to new vehicles is that if you can afford to buy a new vehicle, you have more money and therefore it's less risky for you to take on this kind of a loan?
I don't think so. I think the idea is hopefully that, again, with a new vehicle, that you would have it long enough that, you wouldn't get that upside downness. Whereas with a used vehicle, that can happen immediately. I think that's what they were trying to accomplish, although I wasn't part of the discussions.
If I may, my understanding is once you drive a vehicle off the lot, you're already under, it's worth less than what you paid for it.
Sure.
So-
So
so,
depending
like-
on what kind of down payment you put down.
Yeah.
Whether you have equity or not.
Yeah.
Correct.
Okay.
And my understanding is the limitation on the spread, the lowering the spread is intended also to help that, so that the payments, are a little more consistent. So these products, as I understand it, are designed to have higher payments up front. And I mean, lower payments up front and higher payments later. And so the higher payments later, when the vehicle has depreciated more in value, were more of a concern. And so this, I believe, addresses, is intended to address partially those concerns. So, if there are going to be differences in the payment amounts as they're amortized over time, it's going to be, one payment can't be no more than 30% more than any other payment, as opposed to 50.
Representative Matheson.
Curious when, maybe I should have asked Linda, I apologize. I'm just curious where the 36 came from. Sorry, I should have asked that.
I would say that you, in addition to the superintendent, you also have representatives from Ford who are online. If you have any particular questions from them, I just forgot to remind you all that you had folks and you have in the room as well.
And then, of course, we have Bruce Garrity from the Automobile Association, so lots of places we can ask questions, but we have a pending question if anyone can answer where the 36% came from.
Sorry,
I mean,
should
I'm
have
assuming it
asked.
was a compromise.
Yeah, I'm just curious where the 36 came from. I'm just doing calculations here. If I have a $600 payment, I know I love math here, and I do.
Well, it allowed
It's-
them, it lowered it, it allowed them, it was kind of random. Some states limit it to 40 and some states limit it to 50%, some states limit it to 40%. It was kind of random. I liked it because it was it's twice 18 or whatever. I mean, it made sense to me, but it allows them to run the program successfully. It's large enough to allow them to do this program, but still on the low end to prevent people who have lower credit from getting into this kind of a deal.
So it allowed the spread of payments.
Mhm.
Okay, thank you. That's helpful.
Representative Flynn.
Thank you, Madam Chair. Thank you, Linda.
This legislation was advanced by Ford Motor Credit.
That's
correct?
correct. Mhm.
So I'm making an assumption that if someone is going to avail themselves to this loan, it's going to be a Ford product, correct?
Well, they have a product, but once you change the law, anybody can come up with a product that fits within the law.
Right, so thus the new vehicle designation, so if it's Ford Motor Credit, they're going to sell Ford vehicles. But if it's a Ford dealership and they've got used vehicles on the lot and potentially a new used vehicle on the lot, they could avail a non-Ford product to Ford Motor Credit financing. I'm saying it's not, this is not captive to just Ford products. This is
Correct.
Ford Motor Credit on all new vehicles, correct?
Yes, and again, it's not necessarily just Ford credit.
Right.
Right,
because, you
It's
know,
gonna open it to others.
Right.
Credit unions
Got it.
could start doing it.
Yep.
Other GM, I
Okay.
don't even know what car companies are.
Just trying to see how big a can we're opening.
Yeah.
Fair. All right, any other questions for Linda while she's up here for the second time?
Sorry,
Okay.
Linda.
That's okay, thank you. Representative Foley.
Yeah, I just want to say that, one of the benefits I see of this bill is, it will help out in the beginning of having a new car in the excise tax. You pay your excise tax at the beginning with a new car, it's much higher, but as the years go on, it comes down. So this sort of helps, especially nowadays. I mean, new cars at $60,000-$70,000. Think about the excise tax on that. So that's the benefit I see of giving this sort of finance option to folks. So
Based off of the financing. It's based off what you paid for it, and then it's based on the value every year.
Thank you. Math again.
All right. Representative Flynn.
Thank you, Madam Chair. Another quick question.
Oh.
Just an observation, asking for someone to say if I'm correct or wrong. If we have a York County Ford dealership and they're competing with a Southern New Hampshire dealership, a person from Sanford, Maine, say, could go to New Hampshire, buy the vehicle under this financing program, but could not do it at a Maine dealership. That's correct? Thank you.
Further questions, discussion? Representative Foley?
I'll make a motion not to pass as amended.
Second.
With the change in there of the not previously titled.
Seconded by Representative Olson. Further discussion? Representative Clucci.
Thank you, Madam Chair. I'm hoping that everyone saw the article that I had circulated from Edmunds. So one of the things that one of the highlights is it says that 29.3% of trade-ins toward new vehicle purchases had negative equity. And that the average amount of underwater trade-ins hit an all-time high last year of $7,214. So that means when you go to buy a new car, say it's $60,000, you're now taking out a loan for $67,000. So here's my concern. I think that if cars are really expensive, and I think it's really important that we don't try to just normalize this and say, yeah, no, let's make it easier for people to buy cars that they cannot afford and they will never be able to pay off, right? Because like if you trade in that car after 3 years or 5 years and you're having that negative equity, how many rounds of cars and then suddenly you're, $50,000 in the hole, you're never going to get out of the hole of car debt. And especially in Maine, everybody needs to have a car. So I'm really uncomfortable with creating an opportunity to make it easier for people to get into even more debt. And I think that is what this does. What I'd like to see is the vehicle manufacturers making vehicles that people can afford to buy, rather than forcing everybody to go into debt to buy only the vehicles that are available, which are like super expensive these days. So I unfortunately cannot support the bill. I appreciate that everybody worked hard on it, but it feels like I don't want to be responsible for contributing to additional consumer debt as it relates to cars. And I think that that's what we would be doing if we pass this bill.
Okay. Further discussion? Seeing none, I think we're ready, and Oops.
Thank you. Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Alford.
Yes.
Representative Alford, yes. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Clucci.
No.
Representative Clucci, no. Representative Flynn.
Yes.
Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Olson.
Yes.
Representative Olson, yes. 9 members of the committee having voted in the affirmative and 1 in the negative. And it's going to be,
Representative Clucci, I'm assuming you're ought not to pass. Representative Clucci?
I agree. Yes, I am on not to pass.
Thank you.
Sorry.
All right, so that will conclude the work session on LD 2056. And again, we're going to skip LD 1220. We'll open the work session on LD 2088.
Okay. So LD 2088 is the bill, an act to increase access to primary care provided by physician associates. As it's drafted, the bill removes the requirement for a practice agreement with an active physician for a physician associate who's the principal clinical provider in a practice that does not include a physician. It also makes optional consultations between a physician associate and a physician or other healthcare professional, and removes the requirement that a physician be accessible at all times for purposes of consultation. I think as the committee knows, under current law, physician associates, which were formerly called physician assistants until legislation was enacted last session, may be licensed by either the Board of Licensure in Medicine or the Board of Osteopathic Licensure. There are 2 substantively identical statutes enacted in each licensing chapter that governs the licensing of physician associates. I've attached for you the provision that's in the Board of Osteopathic Licensing statute, which is section 2594F. The counterpart in the Board of Licensure of Medicine chapter is section 3270G. These statutory requirements have been effective since March of 2020, when the 129th legislature enacted legislation, at that time LD 1660, on an emergency basis that became Public Law 2019, Chapter 627. And I also, no, I don't think I did. Prior to enactment of this law, physician assistants were required to practice under the supervision of a physician. The current law sort of has 3 categories in statute that govern sort of the level of consultation, collaboration, communication between physician associates and other healthcare professionals. And under the current law, there's a consultation requirement that applies to all physician associates. And they're required to, as indicated by a patient's condition, the education competencies and the experience of the physician associate and the standards of care, consult with, collaborate with, or refer the patient to an appropriate physician or healthcare professional. The statute says the level of consultation required is determined by the practice setting, including whether there's a physician employer, whether it's a physician group practice or a private practice, or by the system of credentialing and the granting of privileges if a physician associate is employed in a healthcare facility or a hospital. It requires that a physician must be accessible to the physician associate at all times for consultation. It does allow for consultation to occur electronically or through telecommunication. There also is a requirement that physician associates with less than 4,000 hours of clinical practice documented to the board shall work in accordance with what's called a collaborative agreement with an active physician that describes the physician associate's scope of practice, except that a physician associate working in a physician group practice or a healthcare setting under a system of granting privileges or credentialing and a scope of practice agreement may use that system of credentialing and scope of practice agreement in lieu of a collaborative agreement. And then finally, the practice agreement provision requires physician associates who have more than 4,000 hours of clinical practice. It allows them to be the principal clinical provider in a practice that does not include a physician partner, as long as the physician associate has a practice agreement in place with an active physician. And I attached for you just a brief kind of comparison of the current law that I just sort of outlined for you and the changes that are made in LD 2088. So the current law defines a practice agreement. LD 2088 would repeal that agreement because it's repealing the requirement, that definition, because it's also repealing the requirement for a practice agreement. The bill maintains the requirement that physician associates consult with, collaborate with, or refer a patient to an appropriate physician or other healthcare professional. But you'll see it makes that, moves it from affirmative requirement that a physician associate shall do these things to may. So it says it becomes optional. The consultation requirement becomes optional. And it also removes the requirement that a physician must be accessible to the physician associate at all times for consultation. So you'll see that sentence is stricken in the bill. It also, as I said, repeals the requirement that physician associates with more than 4,000 hours of clinical practice may practice independently, be the principal clinical provider in a practice. It removes the requirement that they have for a practice agreement and repeals all of subsection 6. So those are essentially the changes that are made in the bill. What it does maintain is the requirement in current law that physician associates who have less than 4,000 hours of clinical practice shall work in accordance with a collaborative agreement with an active physician. That's not affected by the bill at all. So those physician associates with 4,000 hours or less are still subject to that requirement that they have a collaborative agreement in place. I don't know if anybody has any questions about what the bill does.
Seeing it. Representative Arford.
Thank you. Thank you, Madam Chair. And just to clarify, I get all of this. The only number 4 on when you compare the two current and then the changes from LD 2088, the consultation part, you're talking about consultation while they're engaged in the 4,000 hours of collaborative practice.
It's both. It would be anything, that's not limited by the hours. So it would be a requirement for consultation, whether they have, without regard to their clinical practice hours. So it's sort of under the current law, it's an ongoing responsibility for a physician associate to have a physician available for consultation. That's a shall right now. And then the current law sets up a difference in the types of agreements that are required based on your hours of clinical practice. So someone with less than 4,000 hours is subject to the collaborative agreement requirements, and someone with more than 4,000 hours is allowed to practice independently if they have a practice agreement in place.
So make sure I understand this. So the way it is now, it's very clear, the consultation, the practice agreement requirements. If we pass this law, just in general, at any point in time, either during the 4,000 hours or while they're in independent practice, the consultation is a may versus a shall.
It becomes a may.
Okay. But even during the 4,000 hours of the collaborative practice?
It does, except the collaborative practice agreement is a shall. So
Okay.
someone with the less than 4,000 hours has to have a collaborative agreement
Right.
in place. And that's sort of a written agreement, similar to the practice agreement that's filed with the board, and they have, and the consultation requirement that would become a may is not something that's memorialized in a written document. It's just a, they would have someone available to them, and they would have a response, under the current law, it's almost like they have a responsibility based on, the circumstances, the education, the competency, the experience, standards of care to consult, collaborate with, based on the appropriate circumstances. And the statute says that the level of consultation, how much consultation is required is based on that practice setting. That's not going to change if the bill goes forward, but it does change it from the consultation provision from a shall to a may. And it removes the requirement that a physician must be accessible at all times. That sentence.
Thank you.
Any other questions about current law or what the bill would do?
Yeah, Madam Chair. Colleen, is there, I was trying to find where the collaboration agreements are described? Do we have
Yep.
that in front of us somewhere?
So if you look at page 7, is the copy of the current law. So you define, a collaboration agreement is defined as a document agreed to by a physician associate and a physician that describes the scope of practice as determined by the practice setting, describes the decision-making process for a healthcare team, including communications and consultation among healthcare team members. And the statutory provision that's not affected at all by 2088 for collaborative practice agreements is in subsection 5 there on page 8. And that requirement for collaborative agreements applies to physician associates with less than 4,000 hours of clinical practice. It requires them to work in accordance with a collaborative agreement with an active physician that describes their scope of practice. It does allow that in lieu of a collaborative agreement, if they practice in a group setting or practice in a hospital that has a system of granting, privileges and credentialing, and they have a scope of practice agreement in place, that may act in lieu of the collaborative agreement. But that's not going to, that subsection is not going to change in LD 2088. So that requirement will continue to apply to those physician associates with less than 4,000 hours of clinical practice.
Okay. Any other questions for Colleen? Clarifications?
Okay.
Well, moving.
So then just to kind of highlight some of the things that were talked about at the public hearing, and some of the considerations for the committee as you consider whether to move forward with this bill. You did have information from the Board of Licensure in Medicine about the extent to which their data shows whether or not the current provisions in law that allow physician associates with more than 4,000 hours of clinical practice to practice independently has led to an expansion of access to care. And their testimony noted that since the law was enacted in 2020, they have approved 55 practice agreements. 17 of them have been for aesthetic practices, 17 provide insurance exams, so not providing treatment or diagnosis. 21 have medical practices, and they noted that 5 of those only provide short-term seasonal coverage. And then I'd also note that the testimony that they provided did also provide information about the location of those 55 practice agreements. They also indicated that they have not received any quality of care complaints filed with the board in regard to those 55 practice agreements or those physician associates that are practice under those practice agreements since the bill has been enacted. So to the extent that there are concerns about patient safety or considerations of that, that's what their data shows, at least to date, for that limited, the limited data that they have available. You've also heard testimony about the current requirements for the practice agreement and whether or not that has worked as intended. Oh, sorry.
Representative Cucci, you had a question?
Sorry, thank you. Do we happen to know, so just to clarify, the 21 medical practices that have applied for independent practice, is that 21 sort of entities, or is it 21 individuals?
I believe it's individuals.
Okay.
Because the board licensed individuals.
Okay, so if we're talking about like a convenient MD that employs maybe like 5 PAs, so it could be like there's actually like a smaller number of sort of sites. And I'm wondering if the Board of Medicine could be able to get us actually how many sort of sites we're sort of thinking about or practices.
Yeah, let me look at I'm just looking at their testimony, and I don't know if Mr. Terranova can comment, but if you look at their testimony, which should be in your file, they did indicate the locations of the practice. Of those 21, they did note that, a number of them of the total are focused in, southern areas, but you can see
Thank you.
the breakdown. Yeah.
That's helpful.
Yep. Okay. So I think I was mentioning the extent to which the practice agreement requirement has worked as intended. I mean, you did have some testimony from proponents that indicated some have found it difficult to find physicians willing to enter into practice agreements. And also they noted the costs required to enter into those agreements and arrangements with physicians. One thing also to keep in mind is consider whether or not to retain a notice or reporting requirement to the boards by physician associates that practice independently. As I noted, the bill as drafted repeals the whole provision of statute that applies to practice agreements, and one of the elements of that provision in current law is a requirement that they provide that practice agreement to the board. And the board, you know, it has that information available to them. So if you are interested in sort of tracking or determining the extent to which, if this bill moves forward, physician associates are establishing independent practices, some notice requirement or reporting requirement to the board, you may want to retain that. But the bill as drafted just repeals that altogether. So something to keep in mind.
Oh, I have a question, Polly.
Thank you. If we pass this, if someone has paid the fee up front already, will they get it back?
So it would depend on if the agreement addresses that. Yeah. And then you did have some
Colleen.
information. Oh, sorry.
Representative Clutch.
Thank you, Madam Chair. So Colleen, if we're looking at, so you're saying, right, so it would repeal all of the practice agreement requirements. So in that case, is there a fallback? Because it says, let's see, so the scope of practice for a PA, right, is that they're licensed to provide any medical service for which they have been prepared by education, training, and experience, or are competent to perform. So who decides? So in here, it looks like the licensing board requires, because my question is like, who decides that they've met this criteria and has oversight of what services somebody provides? And it looks like in the current statute, the board is the one to be able to say, like, to request that information so that they know that the person, if they're marketing themselves as somebody who does, like, you know, menopause care, then they've gone through like their menopause training or whatever like that, right? So that there's somebody who's sort of having some oversight. So if we take that away, is there any other mechanism by which the board or somebody would have to sort of legitimize or, you know, be able to like know that the person has actually is, you know, is credentialed to do what they're saying that they're credentialed to do?
Yeah, I mean, there are requirements in the current law related to, you know, scope of practice and determining, you know, and that's typically the statute refers to sort of the practice setting determining that. So I think in most cases that would be determined by the place where the physician associate is employed. And that's how they would determine, you know, what activities, you know, what patients they're seeing, what, you know, areas they're practicing in. It would be determined in those, in that setting. Independently, if they are practicing independently, they would be the ones making that determination. They would have the option to consult with a physician if they felt that the circumstances demonstrated that they were required to consult based on, you know, the language talks about the patient's condition, the practice setting, the competencies of the individual. But there would no longer be a requirement to, or there would no longer be a way for the board to even know who was practicing independently, because there would be no notice, a specific notice of that. They would have the licensing and the license renewal, but there would be no, not that there's a check, but my understanding is now, you know, they file that practice agreement with the board. The board is able to determine whether or not they've met the clinical practice hours in order to qualify for that practice agreement. Removing that altogether, there'd be no, just, you know, raising the suggestion for the committee to consider if you wanted an ability to track or have the board to have this information on file. There's no affirmative requirement for an independently practicing PA to inform the board of that.
Yeah, Representative Lestrade.
Thank you, Madam Chair. So I'm trying to find out the date when we put the 4,000 hours in, and was that put in at the same time that we did?
2020.
Was 2020. It was
Mhm.
when we did the whole,
Yes.
and before that,
It was a supervising requirement, supervision,
for always. Okay, I'm just trying to look at some of this.
the continuum.
I just, yeah, so
That's
just
the
go ahead.
continuum. Yep. Yes. And then finally, I guess I would just,
Colleen,
more questions. Oh, sorry.
Sorry, one more.
on.
So if somebody, so if somebody does their 4,000 hours, right, and then they stop practicing because of something comes up in their life, maybe they've had a baby and they don't practice for 10 years. But they keep, I mean, guess, but they somehow keep their license through doing CME, but they're not actually necessarily seeing. I mean, I guess, can they keep their license, and how do they keep their license? And then, like, if they were to come back into practice, a decade later, how do we know that their skills are still sharp, that their research is still up to date, that kind of thing? Is there any sort of oversight that would help us ensure that that kind of stuff is being done?
I'll defer to the board. I don't know, representative, both boards are here, but I thought Mr. Terranova was here. But my understanding is if they, as long as they keep an active license, which would require them to keep up with the CMEs, I'm not sure that there's any specific board function that tracks that. I think they're,
I think they have requirements like any professional.
Yeah, yeah. And they'd be treated just like a physician in the same circumstance, is my
A
understanding.
nurse practitioner, or,
Yeah.
they all have their licensing requirements. Representative Harford.
Thank you, Madam Chair. So based on what I was just hearing, if I was a PA licensed, I've completed my 4,000 hours of supervisory practice, and then I decide, well, I'm going to go I decide I'm going to raise a family. So as Representative Clucci mentioned, I stopped practicing at that point for a period of maybe 6 years. But during that time, I would still have to keep my license up. I would still have to be doing the relicensing, the CPEs, whatever was required to keep my license. Otherwise, the only other part of this question I don't understand is if I didn't do any of that and I allowed my license to lapse, when I came back 10 years later, if I wanted to, what would I have to do? My license now has lapsed. It's no longer active. But would I have to, would that be it? I mean, could I go back into the field?
Again, they would have requirements, but I would just say none of that is changed by this bill.
Right, I understand.
Yeah. So
Okay.
it's going to be the same whether we pass this bill or not.
All right.
That's not going to change. Whatever those requirements are.
Thank you.
Okay, the final two things I guess I would note. You did hear at the public hearing that there have been 7 states that have enacted legislation. There are other states that are considering it, but that have enacted legislation that would allow a physician associate to practice independently. The requirements and conditions do vary among the states, and so I just outlined for you the states and what their requirements are. They do range. They have different levels of clinical practice hours, ranging from, states that are similar to Maine's 4,000 hours. Some states are higher. Some states have, requirements for continued consultation, collaboration, and referral, similar to what's in, our state law that I noted. Some of those states have language that says shall, consult, collaborate, refer. As I mentioned, LD 2088 moves that to may. Some states have it be a may. Other states have no specific, no specific requirements beyond that. So I don't think I'll necessarily go through all of them, but the 7 states are Iowa, Montana, New Hampshire, North Dakota, South Dakota, Utah, and Wyoming. I would note that New Hampshire's law is effective January of 2027. So while it's been enacted, it's not effective yet, but it would allow physician assistants with more than 8,000 postgraduate clinical practice hours to practice independently. That's the closest state to Maine, so I just note that as for purposes of comparison. And then finally, I think everybody's aware, but the bill is drafted as an emergency, so although there's a typo in the title. And then the indication that we have from the licensing boards is that any additional costs to implement the changes can be absorbed within existing budgeted resources. Guess I'll stop there. Happy to answer other questions that you might have.
Very good.
Representative Arford?
Thank you. Thank you, Madam Chair. And I understand that the 7 states that currently have a path forward for independent practice without a practice agreement, they all do it a little, they all have different requirements leading into it. They do it a little bit differently. But I'm looking at New Hampshire because that's our next door neighbor. And it appears that they require 8,000 hours postgraduate clinical practice before the person can actually practice independently. And do you know whether or not those 8,000 hours are with a supervisory agreement, or it's just 8,000 hours of practicing, not but not independently?
Well, it wouldn't be independently because you'd have to, the statute requires that they wouldn't be able to practice independently until they've had those 8,000
Right, but they wouldn't have,
hours.
they wouldn't necessarily have to have a supervisory agreement. They could just be working somewhere. I mean, they could just
Yeah,
be
but
working
they
in a
would be
setting
working
that-
in a setting that
had
has, you know, physicians
doctors
and
and
or
DOs
others
in it.
available. Yes.
Yes, so
Yeah.
as far as we know, it doesn't require a supervisory agreement. Like,
Well, there are, I'd have to go back and look more specifically. I don't think I call it a supervising agreement, but most states have some sort of requirement for collaboration and consultation. And many states have a requirement like Maine that there be an agreement in place that describes that, whether it's a scope of practice agreement, some states call it that. Some states use similar terminology to Maine, which is like collaborative agreement that would be in place for those physician assistants that have fewer hours of clinical practice. So there would be something, my understanding is New Hampshire has something in place that would allow them to do that. They're moving to that requirement in New Hampshire where they would remove any sort of requirement for a practice agreement. My understanding of how it works now is there's an opportunity to apply for a waiver to their board. If you have that 8,000, you know, clinical practice hours, but they're moving to sort of removing those types of requirements altogether in New Hampshire as of 1/1/27, as I understand.
Representative Mastrapio?
Thank you, Madam Chair. So I'm just wondering, rather than just, I mean, because I think that what we intended for the collaborative agreement to be, it didn't turn out to be that. I didn't ever think it was just going to be pay me the money and I'll sign a paper that I'm here if you need me, but I don't have to document anything. And to be fair, I know that the physicians that I deal with in my town are incredibly busy, and I can see why that would be something that the person who wasn't working for them that they would want to take on. I get that. So is there a possibility that we could say that if we could separate it and we could say if you're practicing independently, you'd have to maintain that collaborative agreement if you only for a certain period of time until you have a certain number of hours. And the people entering would have to have a certain number of hours to enter independent practice with a few more hours. Because I am seeing that there's a big difference in the number of hours that are required. Just saying, let's just think about it a little differently, that we can get the same thing accomplished at the end, and see if there's a way that we could do that without impacting the people that are, I mean, I don't want to penalize people who have already been able to do this. They have a collaborative agreement. I mean, they're obviously doing it, but I think there's a better way to do it because I never intended for somebody to pay $10,000 a year for that. So I'm just, do you understand what I'm asking, Colleen? A way to like ease our way into it.
Representative Clucci?
Thank you, Madam Chair. The other thing I'm sort of noticing is that some of these other states, they're keeping agreements in place or they're having to provide their scope of practice to the board and sort of demonstrate their competency. So I would, you know, it's really important to me that there's some sort of demonstration of competency to the board, that there's some amount of oversight. But the other thing I'm curious about is that the other states that are requiring agreements, whether they call them collaborative or practice or whatever, are they experiencing the exact same issues Maine are, that it's just a checkbox that you're paying a monthly fee for, or are they adding value?
That I don't know. I wasn't able to find any of that information. I know you've had some testimony about studies that have been done about, you know, the potential impact on medical malpractice for, you know, expansion of scope of practice that would allow independent practice. And some of the studies that were noted in your testimony noted that there was no sort of adverse impact on medical malpractice or an increase in claims associated with those providers that were practicing independently. But I don't know if haven't seen anything like you asked in terms of data on that. And I don't know if anybody else has.
Additional questions or discussion? Representative Art?
Thank you very much, Madam Chair. And I just want to acknowledge that this is a tough conversation, I think, at least for myself, because I fully acknowledge that the PA profession is a profession that would love to grow itself, has every right to grow itself, has every right to expand itself, to move forward in directions which will allow it to just simply grow and do more and serve more. And at the same time, at least in my case, I have this concern of how we, at the same time as we move that forward, we also allow for the considerations of how that may impact the patients that will be served in terms of patient safety and quality of care and a number of other factors that we're really not discussing in this bill, but that are somewhat addressed in Mr. Terranova's testimony. And so the question I'm thinking about right now is, one of the things I've heard from almost everybody who's asked me to support this bill is they've also said, support this bill because we all know that we need to have more highly qualified providers in those areas of our state where we currently don't have any. And so Mr. Terranova gives us this great information on that, about where the current people that are in independent practice, where they're practicing. And we have the map of the state that shows us where they've gone. And he also says that if we were to pass this bill as is, we would lose our ability to do that. He specifically says, if passed, BOLEM would not, passed as it currently is, be able to track the impact on whether or not this does actually end up in physician associates setting up independent practices in the parts of our state, which are mostly rural, where we currently have a dire need for providers. And he says they would not be able to track the impact, as there is no notice or reporting requirement included in this bill. So one of the things that would make me that would allow me to be more comfortable in supporting this bill was that if we amended it with some sort of a simple notification mechanism, so that when after the 4,000 hours of supervisory practice have been completed and a physician's assistant decides that they in fact do want to set up an independent practice, that there would be a mechanism for notifying the board. And that would include specific pieces of information, where the practice was going to be located, what their scope of practice would be. It would be very basic information that would be reported. And then if that was to change in the future, they would notify the board. And that could be done, and it could be done for a separate notification. It could potentially be done at the time of relicensing, but that would be something to me that would allow at least everybody who is very interested in understanding what, if we were to pass this bill, whether or not it actually was able to significantly influence where physician associates are practicing in our state, that would be something that I would definitely support. So I just want to put that out there.
Additional comments, discussion? Representative Clucci?
Thank you, Madam Chair. So I'm curious what it would look like if we were to change the practice requirement or the practice agreement to just have it continue being like a collaborative agreement. Like, would that add the value that I think some of us, that like what I heard from Rep. Beth Strapio, that like there was interest in trying to make sure that there was some ongoing support. Could we, if we replaced the practice agreement with a collaborative agreement, what would that look like? And so you can practice independently, but you do have a collaboration agreement. And Colleen, that's not necessarily for you. It's more, it's more just like throwing it out for just sort of discussion among the
Senator
group.
Bailey.
Yeah.
Yeah.
The setting.
I think I know what you're getting at, but it doesn't really work because again, collaboration agreements are really for PAs working in a healthcare setting or a medical group. And so that's why those were separated out, because a practice agreement is for a PA working independently. So if you're having a collaboration agreement, you're not working independently. So.
But are they intended to achieve the same goal?
Yes and no, but again, they're different animals, right? Because again, a PA working independently is different than a PA working in a healthcare setting.
I mean, one thing you could look at subsection 4, which is the consultation, and the bill removes the shall to a may. If you kept it at a shall, that would apply to a PA practicing independently, and maybe you could make some other changes to reflect PAs that are practicing independently in that subsection. It's not a collaborative agreement, but it's sort of an ongoing responsibility for consultation.
How does
Certain
that,
circumstances, but I don't know if that's
how does that play out in
what
real
you're getting.
life? Like, I don't understand that. Yes,
Yeah.
Representative Mastracchio.
Thank you, Madam Chair. And I'm not saying that I necessarily agree with that, but it would play out in real life if there was a problem. And you, as a PA practicing independently, did not consult and it was determined that you should have, then I would say that's when it would play out. So it can work.
You'd be subject to malpractice.
Yeah,
Yeah.
absolutely. I would just like to add to that I'm looking at all the states that have independent practice, and they are all rural states like ours with different varying degrees of, and I'm trying to check and see what I can determine as to how different they are. But I think that it seems like, and if you look at the progression of where they got to that plate, it's kind of the same thing that we've done, which implies that there's no, that there's a little more trust that is developed between the professions. I mean, maybe I'm just wishing that, but I think that I get that I think physicians realize they can't see everybody. I mean, that it's physically impossible. So I just want to keep working on this to see that what we get is the best mix and the best solution to protect the public.
Representative Clucci.
Thank you. Well, and so, right, there are not enough physicians to treat everybody. And so I think that my goal with having, physician associates and nurse practitioners is that in theory, they're taking on the management of patients that have less complicated care requirements. But so the way I envision that is that then you work with somebody that can provide that higher level care when that comes up. And so I'm trying to think about from a patient safety perspective. Most people that are looking for primary care aren't necessarily going to know the difference between a PA and an NP and a DO or an MD. They're just thinking they're going to be able to get great care from anybody and from right? They're just looking for primary care. And if they have higher levels of need or, I think it's important that there be teams working together. And so, And if we are really trying to like, if as Rep. Mastracchio said, the states that are expanding this, they're rural states like ours, is the goal really to like expand access to primary care? Like, I think that would be the goal. Are we doing that? You know, I see like anesthetist or I can't pronounce the word. I see insurance people. They're not providing primary care. And the medical groups, like how many of these are urgent care versus actually truly providing primary care that we're like really looking for to fill the gaps in our healthcare system. And so like, I want to be passing laws that help put us in the right place for where we want to be. And
Great, thank
Yeah.
you. Appreciate that. I just want to clarify too, for me, where I stand on this bill is that I do support it as is. I think it's really important to understand that most providers want to practice within their scope of practice, and most providers have already established collaborative agreements with many, many other providers. And I don't know that I, as a legislator, want to mandate how that is determined for a provider. So I don't totally agree with that, with including in statute what the consultation must be. I don't support that, but Representative Boyer, did you have a question or a comment or?
I think I forgot it. I just wanted to respond to Representative Clucci. In this list that we received from Mr. Terranova, it's not going to be, these are practice agreements, so it wouldn't be a provider with multiple, like I'm sorry, I can't remember what you called it, an urgent care or whatever, because that wouldn't require a practice agreement if a PA was working at that. So these would be practice agreements, which would indicate it was someone working independently, not working for like a urgent care.
Representative Foley?
Thank you, Madam Chair. You know, over the course of my lifetime, I've seen doctors for a number of reasons, but I've had occasions where I've seen a doctor and they're not comfortable treating whatever the issue was that I had, and they would send me to a specialist or to somebody who they felt more comfortable with. So I don't really think that any physician associate is going to do anything that they're not comfortable doing. It just, I think that they would say, hey, this is a little bit more than I'm capable of handling. Let's get you to see somebody else. So I just think that's the way the practices work and in the medical field works. You know, if you have a primary care physician and they think you have cancer, they're going to send you to a cancer specialist. Or if they think you have a heart condition, they're going to send you to a cardiologist. I mean, that's just how it works. So I just don't, I'm not concerned that people are going to practice outside of the scope of practice. I think they know what they're capable of and they know what they're not. And you're right, malpractice insurance, they don't want to jeopardize that. So they're not going to go out on a limb and jeopardize, you know, their malpractice insurance. So I'm very comfortable with where we're at on this bill.
Thank you. Just want to make sure there's nobody else that hasn't spoken. Okay. Representative Orford?
So I just want to thank everybody for all the attempts we're making to find a place where we're all comfortable. And Representative Clucci, the issue I'd have with changing the language is we're talking about people that are going out into independent practice. So they may actually be the sole practitioner in an office setting. And it may be, hopefully, in a rural part of our state. So they simply may not have access to someone on a regular basis to collaborate with. They are no longer in a practice setting or in a hospital or a place like setting like that. That's the whole point of this. So they can practice independently. So as much as I love that idea, my concern is we'd be doing the same thing that happened in 2020 when we came up with what at the time seemed like a solution to do these practice agreements. And now we're hearing that didn't work at all. First of all, it became a whole nother business for MDs and DOs to charge physician's assistants, physician associates to be their to be their person in their practice agreement. And so it actually became, if you will, almost unaffordable to do that part of the plan. And so as much as we all, I think, agree that collaboration should be a must, whether or not it could be a must without that person having to pay money for it or having to set up some sort of an agreement with someone to be their collaborator, I don't know. I honestly can't say I think for sure that would work or wouldn't work. Although I love the idea that Representative Clucci put that out there. And the other thing I want to note that if any of you haven't seen the sheet that identifies to practice independently in New Hampshire, which is our border mate, prior to being able to start your independent practice, you have to have 8,000 hours of collaborative practice. In Maine, we have to have 4,000 hours of collaborative practice. And I just think we should think about the dynamic that would set up between our two states. So in other words, New Hampshire is requiring people who start their independent practice to have more time in the saddle in a collaborative practice agreement than Maine would be, and whether or not that's what we want to do. Okay,
Great,
that's it.
thank you. So I just wanted to also just clarify that these consultation hours in statute right now can occur electronically or through telecommunication. So the person doesn't have to be in the setting with them. So someone that might be independently practicing could do this through consultation electronically, and that's already in statute. There was yes, Senator Bailey.
I'd just like to make a motion.
Yep.
I would move to pass.
I'll second that. Discussion, Representative Clucci. Yes.
Thank you, Madam Chair. So we did get some testimony from an urgent care center. They plan to employ 10 healthcare professionals, but they don't want any of them to be, they want them all to be PAs, but that's expensive because then they have to do practice agreements for everybody. So that was, I knew I wasn't making that up. That came from somewhere. But then what I've heard a lot of people say on this committee is that as long as people are practicing in their scope of practice, then that's fine. The issue is that when you are in an independent practice as a physician associate, you get to define your own scope of practice. And there is no one to double check that you actually have the credentials to do that. And I know, yes, most people do consult with colleagues, right? And set those relationships up because they know it's the best practice for medicine. But we don't necessarily, like, the licensing board is here to protect against the people that are not going to do the right thing. And so I think it's really unfortunate that we have a situation where these practice agreements have become so meaningless. I don't think that, had I been a member of the committee, I don't think I would have supported something that was going to become meaningless. I don't want independent practice PAs setting their own scope of practice without proving that to somebody. I think that's dangerous to not have somebody overseeing, to at least be able to verify that they have had the training that they say they have. And so
Yeah, just wanted, there are a couple other people.
Yep. Right. So I'm very much I don't think that we're ready to vote on this bill. I think that we could do some work to find some common ground and compromise. So I would like more time to be able to come up with a proposal that I think maybe I could be more comfortable with. So
thank you. I saw two hands up, but they went down. Yep, Representative Arford.
Yeah, I'm just wondering whether or not the senator, if the motion maker would be willing to table this until next week, where we would have more time to come up with something that we could get a unanimous vote for.
You know, I always try to get unanimous votes if that's possible. I'm not hearing that that's going to be possible on this bill, given the concerns that I've heard. I'm open to discussion if people are hearing something else and think that is possible.
Representative Mastrokia?
Could I just have clarified again the question about the notification piece of who's going into independent practice would be missing now if we pass this as is? I am really concerned about that because I think we should know how many are leaving where they are and going out independently. If nothing else, then at some time in the future, when we might put in a bill that wants us to tell us where all the medical professionals are. So, and I don't want that to not, so I guess I would prefer to have that little piece in there. I mean, I know it, for me, it's just simple, you know, and I heard from the board that it wouldn't be in there. And I do think I would want to know if we had 500 PAs, how many of them are in independent practice? Just if we ask that question in 2 years, somebody asks your analyst that question and you'd like to know that answer. So unless there's a objection to that, would that be an amendment that you would put on there? And just tell me why
Senator
not if
Bailey.
not.
Yeah, again, the difficulty is again how you require that, because now the way they gather that information is through a practice agreement. We're not requiring practice agreements anymore. So how do you require that information? And I do think it's a discussion to have, and I do think it is good information to have for all healthcare practitioners, because, you know, we do need more information on where people are practicing and, you know, where the need is, et cetera. So yes, I did think about that, but I don't know how to do that mechanically. Yeah.
Representative Mastrokia?
Thank you. I'm just asking because I would like to know that in the future, it's something that's going to be on your radar, because I do think it is important for us to know when people come in and say, oh, there's no access. And then every time we have to sit down and dig out that information, that should be something that's easily accessible to us.
Senator Bailey?
So yes, it is in my radar. And again, I don't know if it's something we should do as part of the licensing process, if it's something we could do through MHDO and have a healthcare practitioners report there. I haven't, and I'm open to suggestions of, you know, other people, how they think that should work and how we could gather that information. I haven't figured it out yet, but I think we do need to do that. Yes. But I think that's a separate bill and a separate discussion.
I also think it's really important to consider that for all healthcare providers, not just for, Representative Foley?
I mean, I do know that when we had our commission, one of the things we talked about was re-erecting the health board that we used to have.
Oh, that's right.
And I don't think we agreed to put a bill in to address that. But that was one of the things that we talked about, was to have this commission and have them sort of the state of Maine's healthcare.
Yeah.
And that's where they would certainly want to track, you know, where.
Right.
And so that to me would be the vehicle to try to accomplish that. And you know, if we want to put in a bill to bring that back, I know.
Because that commission didn't have enough bills already, so let's do another one.
But I think that would be an appropriate way to do it. Perhaps not in this legislature, but probably in another.
Yep.
Representative Olson?
Thank you, Madam Chair. I mean, you already have the Board of Licensure is touching all these people on an ongoing basis. It seems to me a logical place that they, in their renewal application or origin puts in that, you know, I'm practicing it in XYZ. And then they can upload that as need be. But I mean, you already have the touch points existing, because they've got to keep that license active and do the renewals and things like that. So, you know, shouldn't be a reach to have them add that extra information.
Representative Clucci?
Thank you, Madam Chair. So, if we pass this bill, can PAs start offering the surgeries that the optometrists want to offer? Like, what's to stop them? I'm very serious about that question.
It's,
I'm not saying that they would, right? But could they?
I think probably
And
their
that's-
license would stop them from
What-
that and
but what is it-
malpractice.
What would their
because the-
license?
the
Their license.
Board regulates their scope of practice.
No, the board does not regulate their scope of practice. If you are an independent practice, the board does not regulate your scope of practice.
But your
Full
license.
stop. Like,
So it does say in the scope of practice that they can do procedures, and I don't want for us to get into some sort of a discourse now. We would need to have some people come and give us additional information, I think, but it does say their scope of practice is procedures. And I'm really trying to keep this as simple as possible. Clearly, some of us have concerns, and I think it is important we address those concerns. Like, for instance, I've already suggested that in terms of the where the person is practicing, their actual independent practice is located, we could have a simple notification. They simply notify the board. I think the board has already expressed, at least to some of us personally, that there'd be no expense involved, et cetera, et cetera. But I'm still thinking if we could just wait 1 week to vote on this bill, we can really have an opportunity to talk about these things with the people who are most concerned about it in our audience. They're sitting there now just maybe possibly wanting to have further conversation with us. And this is not, a work session is not the place to do it. So I'm still going to put it out there that tabling it now and voting on it next week would maybe be a judicious, a very positive thing that we could do at this point. Because I think it is possible that we could reach agreement, something that we could all stand by, I should say.
I have to be honest, I'm not inclined to see that there is a unanimous position, but open to hearing otherwise from committee members. Representative Morris.
Thank you, Madam Chair. I am certainly comfortable with the motion on the floor, to support the motion on the floor. I think when this bill came up a few years ago, this was a very, very hotly contested bill, a lot of discussion, and for this, the public hearing was fairly straightforward, I thought, not a lot of controversy. I think and the sponsors here, she can correct me if I'm wrong, I believe, and as well as some of the advocates, what we're trying to get at here is having some sort of parity with the nurse practitioners. And I think that this has kind of accomplished, that's what we're trying to accomplish here and what we kind of have. So I'm very comfortable with the motion as it is, and we'll support it.
Thank you.
Oh, sorry.
Representative Hartford.
My final statement is this: if we were to table it for 1 week, I will make a commitment to work with whoever needs to be worked with, including Representative Clucci and Representative Mastracchio and other people that have concerns, to try to reach an agreement we can all vote in favor of. I will personally make that commitment.
Thank you, Representative. Additional discussion? Representative Clucci.
I mean, my biggest concern is just that I want there to be oversight of what the scope of practice is. And so if anybody around this horseshoe is willing to entertain that, then, I think we can probably come to agreement. But if nobody wants oversight on scope of practice, then I'm probably never going to get to a yes on this.
Thank you. Additional comments, questions? I think we're ready for a vote.
Thank you. Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Alport.
No.
Representative Alport, no. Representative Boyer.
Yes.
Representative Boyer, yes. Representative Clucci.
No.
Representative Clucci, no. Representative Flynn.
Yes.
Representative Flynn, yes. Representative Foley.
Yes.
Representative Foley, yes. Representative Mastracchio.
Yes.
Representative Mastracchio, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Olson.
Yes.
Representative Olson, yes. 8 members of the committee having voted in the affirmative and 2 in the negative.
What is your minority report?
Yeah, I mean, since we don't have time to develop a thoughtful report, then I don't know, is that something where we would be allowed to do? Do we would have time to come up with a minority report, or would it have to just be ought not to pass?
Well, if you could articulate what your minority report would be, you could outline an amendment verbally. And then I could draft that and bring that back to you. But the rules do require you to say outline what your proposal would be right now.
I mean, if we can have a caucus, then Poppy and I can maybe, or Rep. Arford and I can spend a few minutes and see if we can get that together.
Would you like a 5-minute caucus?
Sure.
Okay, thank you. We'll just take 5 minutes. To wait till Sally gets back now. Okay. Welcome back. Thank you for waiting for a couple of minutes. We have a minority report.
Okay, I'm gonna take a stab at this and then Rep. Artford will correct me for whatever I get wrong. So, what we'd like to do is, eliminate the requirement for the signed agreement. However, what we want to keep is, when you start, what we want to do is when you start as an independent practice provider, you need to go to the board and describe your scope of practice and the location where you will be practicing. And then the Board of Licensure and Medicine can do its thing to sort of to figure out the scope of practice. But so that's it, right?
Just one little caveat is if at some point in the future that changes, either the location or the scope, you go back to the board. And so there's an time, real-time record being kept.
Great. Thank you.
Thank you.
So we are closing the work session for LD 2088 and we will open up the work session for LD 1220. And I think we have
You do. So LD 1220 was a carryover bill and the committee had asked that the Department of Professional and Financial Regulation through the Office of Professional and Occupational Regulation convene a stakeholder group representing chiropractors and veterinarians and look at a number of factors and evaluate the proposal that the committee had asked them to look at, which would provide a licensing pathway for chiropractors to treat animals. And the stakeholder group has been meeting and has given the committee a report. And my understanding is how you'd like to proceed today is to get a brief update from Ms. Valencourt, who filed the report with the committee on Monday. And then perhaps you could hear from each of the parties as well, but she's here. You should have, here it is. You should have had this distributed, you had this distributed to electronically, but you should see a hard copy of the report in your bill folders as well.
Great. So thank you, Colleen. Miss Valencourt, thank you. Don't mind coming and giving us a brief summary? That'd be great.
Tricky riddle. Good afternoon, Penny Valencourt, Director of OPFOR, and thank you very much for the opportunity. It will be brief, only because the report is brief, and we did that intentionally. As we started this assignment, it became apparent that that we weren't going to be able to do a full-blown sunrise review criteria based on the statutory components of it. It's very technical driven. So what we did instead, because this was a bill that was expanding a scope of practice, was to take advantage of that stakeholder process to collect, review, and evaluate data specific to how other states regulate the practice, identify the minimum standards and examination requirements necessary to protect the public, and to consider collaborative agreements or alternative ways in which coordination of animal patient care could be established between chiropractors and veterinarians. As noted in the report, to that end, OPOR convened a stakeholder group, reached out to stakeholders who had expressed an interest in participating, and we set 3 meeting dates: January 30th, the first date was January 23rd, January 30th, and most recently, February 6th. Again, part of the report was to collect as much information about what other states are doing. And I think in part you've heard that information at the public hearing, so I don't have a lot more to offer to that end. However, what I thought was helpful for the committee to hear is what are the existing training programs and or examinations available. And so I focused on that in part as part of the report back and in the consensus. But again, I don't want to get too far ahead of what the rest of the report reveals. And then we also wanted to know what information or data from those states who do authorize chiropractors to treat animals, what experience have they gained or information about? To what extent is the care now provided in those states? To what extent there have been disciplinary actions taken? And Mr. Reed with the Maine Chiropractic Association did provide a response to that, noting that challenging to collect it. This was a big lift and a big ask, but at least a first indicator of data is that there are no disciplinary actions taken that we can see from other states. So that was helpful. I think the other highlight of this report from OPOR's perspective is that it is not making any independent findings or recommendations. Rather, we're reporting back that the stakeholder process revealed that there were areas of consensus. And that was between 2 primary groups, the Maine Chiropractic Association and the Maine Veterinary Medicine Association. And I can highlight those areas of common ground a little bit later, but would just again highlight the area of further discussion with the committee will be whether or not, or how to structure this coordination of animal care, whether it be through a practice agreement, a referral. And I had mentioned to the group that in my experience with some of the expansions of practice among 2 different boards would be a medical clearance of sorts. You may recall years ago that denturists used to have to must have had the patient receive a medical clearance from a dentist before treating. And I think that's consistent. And again, my memory may be off a little bit, but with hearing aid dealers and fitters at some point also used to have to get some sort of medical clearance from an MD to treat a patient. And that really captured, again, sort of the public protection component to ensure that there were no other contraindicators for the type of treatment or the referral that needed to occur. So again, I offer that up not as a solution, but more as background to my experience and how two different providers would coordinate care in the absence of an agreement and in the absence of a referral. OPOR staff was also transparent to the group that the report would not reflect all technical aspects of the Sunrise Review or a full report of the stakeholder discussions, but it would rely on the proponents and opponents to submit or to supplement this report by communicating directly with the committee given the legislative session deadlines. Page 3 of the report provides data within OPOR. We have 395 actively licensed chiropractors, 1,099 actively licensed veterinarians. We will highlight that part of the challenge that OPOR faces is we don't collect workforce data. So that's an initiative I'd like to preserve for a later time, but we recognize that this is a role for which OPOR is going to grow into over time. That being said, we did get some information from the Maine Chiropractic Association in the collection of their data to show where there are geographic practice information on chiropractors in Maine. We also received information from the associations identifying that there are 182 chiropractic members of the association, and then respectively 581 members of the Maine Veterinary Medical Association. There was consensus among the group that minimum educational examination standards are necessary to ensure that the competency of expending the authority is sufficient to protect the public. There was also consensus that the public should be made aware of chiropractors who have met those minimum standards. This really raised a discussion about how other OPOR boards structure this expanded scope. And so there was discussion about instead of adding a separate license to the board, you could simply add an authority to practice similar to what we do with some other programs, and the public has access to that information. There was discussion about potential harm to animals if not regulated, and it includes unnecessary and harmful chiropractic treatments performed on animals at the request of animal owners, undetected diseases and/or medical conditions present at time of chiropractic treatment, which may compromise overall health of an animal. And as I noted earlier, those contraindicators to treatment. And that there is a lack of contagious, infectious, and zoonotic disease control training in order to provide such care. I did want to highlight to the committee that as part of my testimony on this bill last, well, I don't know what year I'm in right now. It's been a busy year. Last year. Thank you for that. At the time, it was not known whether or not, or rather, I think I had testified that OPOR had not received any complaints, but I did a little further investigation of my own. And as it turns out, 4 complaints have been received by the Office of Professional and Occupational Regulation. 2 were filed in 1996. And I don't have the exact data, but another was filed, I think, later in 1998 and 2011. And best to my knowledge, that they were likely closed back to or due to lack of jurisdiction, and that those cases would have been referred out to the Office of the Maine Attorney General for unlicensed practice. So I just wanted to make clear that the footnote is made apparent to the committee on that.
Are you on page 3?
I'm on page 3. There's that little footnote. Oh, poor. Yeah, my apologies.
4.
Correct.
Thank you.
So I think, again, that sort of highlights that there is consensus that this needs to be a regulated practice. We also learned that there are postgraduate training programs granting certification in animal chiropractic care, and it's available to both licensed chiropractors and licensed veterinarians. We did request to have a representative from one of those organizations appear, but they were unavailable due to, and again, this was a very tight scheduling stakeholder process. what I learned and what was provided by Mr. Reed is that there are international and nationally recognized organizations that grant accreditation to providers who issue certificates to graduates. So again, I think for my purpose, I learned that this is really a two-step. These organizations grant the accreditation status to providers who then offer the training. So it's not as though the chiropractor is going to go right to this national organization to get the certificate. They're going to go to a provider that's been approved by them. So that was an important distinction. And through that, I learned that these national organizations require that providers have at least a program that includes 210 hours of certified hours, that the program admits both licensed veterinarians and chiropractors. And it's, again, my initial review of information reveals that this is very much a coordinated effort by way of the instructors and participants are cross-licensed in both professions. I also learned that the program must include competency and common activities described by the professional practice analysis of the AVCA, which is also footnoted. So again, that gives you a further breakdown of what the competency areas are. I did a quick review of the curriculum and I don't want to read it all, but I think, again, I highlighted in that following paragraph on page 4 what those common curriculum content areas are. OPOR did not do a cost benefit analysis, and it's unknown if the expansion of scope would increase the availability of services. This initiative, as reported to the stakeholder group, is not brought forward as an access to animal care issue. Rather, it was at the request of 2 chiropractors who are enrolled in a training program and wish to perform animal chiropractic services. And that may be an understatement of the position of the Maine Chiropractic Association. So I would just, I don't want to overemphasize that point, but rely on the Maine Chiropractic Association to provide any additional information to the committee about that. We did a review of the existing laws and regulations, and as noted earlier in our testimony, currently, if the Board of Chiropractic Licensure or the Board of Veterinary Medicine received a complaint alleging that a chiropractor was performing unlicensed care on animal patients, then the respective board, based on a review of the specific facts, would likely refer that to the Office of the Attorney General for unlicensed practice. However, if this proposal were to move forward, then the Board of Chiropractic Licensure would have jurisdiction to investigate allegations of incompetent or unprofessional conduct of chiropractors licensed to perform animal care. There was also further discussion about, well, how would an existing board of chiropractors be able to assess a case if they themselves don't have that training? And so there was discussion that, not unlike some other boards, you would have to have an expert do that case, but it wouldn't be an expert hired by the board or identified by the board. In fact, it would have to be someone OPOR and in working with the Office of the Attorney General to identify an appropriate expert on a case-by-case basis. So we wanted to at least be able to expressly say to this committee, if this is the model going forward, there would be an opportunity to have an expert review those cases. I don't want to get ahead of myself, but there's a footnote I want to add to that point later on. Mr. Reed with the Maine Chiropractic Association did provide, again, more information from 9 states that provide direct access, as well as information on other states that have a combination of either a practice agreement and or, again, I don't want to misspeak, but I think a referral. I think consistent with other expansion issues that come before OPOR, this committee is, every state does it a little bit different. So I think this is good information to have. But again, I did not want to reach any conclusions about which one state is doing it better than the other. The focus primarily of the February 6th meeting was to review the draft proposed committee amendment that was forwarded to me in April and June, and to use that as the basis by which the group could communicate back to the committee areas of consensus and then communicate areas of changes. So I'll go through this a little bit more, and I may lean in on Colleen if you don't mind, Colleen, because this part is where I need some assistance, but I'm going to take out as part of your packet the committee's amendment that was sent to us. And I'm going to use that as my grounding place, if you will. Areas of consensus, bill title. That's the easiest one. Let those who know what they're doing do what they do. Moving on to definitions.
I think it's the one
My
on the yellow
apologies.
sheet.
So there's
So-
one there's a committee amendment that's included in the packet.
I believe it's the yellow sheet.
It's right after the committee's letter, so it would be in the first appendix. Yeah, that's
8 or 9
that's what we're
pages in.
talking about. Yeah. And it would be yellow or in your own folder. Yeah.
So in getting to the definitions, there was agreement to define animal chiropractic care by amending it to read needs the evaluation and treatment of an animal's vertebral or extremity joint dysfunction through the manual, spinal, and joint manipulation of the musculoskeletal system, and excludes medical diagnosis and systemic disease treatment. But through that discussion, there was consensus that a separate definition of evaluation was appropriate, and whether that's evaluation and treatment or just evaluation, we'll defer to the committee on that. But again, I provided what I thought was proposed language to include evaluation, but again, that's open, I think, for discussion. But what was submitted to the committee was evaluation means a comprehensive clinical assessment and physical examination to assess the animal's musculoskeletal health, focusing on posture, gait, and movement patterns. A chiropractor providing animal chiropractic care must refer animal care to a licensed veterinarian for imaging, laboratory work, or other diagnostic testing if they suspect underlying conditions exist. And again, I put a note there that that's language that OPOR submitted. And again, that I don't want to overestimate that was by any means consensus language.
So Penny, so B, 2 or II was not a consensus area.
The consensus was to add a definition of evaluation,
Okay,
not.
but not the
not
definition.
this exact language.
Got it.
I'm sure there's a better way to write that.
Thank you.
You're welcome. The next is with regard to certification to perform animal chiropractic care. After receiving clarification from Mr. Reed during the February 6th meeting, it was agreed that the chiropractors would have to not only do the training and pass the exam, but obtain the national certification that's offered through the Animal Chiropractic Certification Commission. And again, that's a rigorous, I included the footnote so that you could see that the rigorous requirements to obtain that certification. In the alternative, there may be other organizations other than the ACCC who over time may develop certification. And to that end, we've included language that said, or basic chiropractic animal training programs and examinations pre-approved by the board. And again, that's somewhat consistent language we have across many boards. The next section, which the group agreed is specific to the continuing education requirements noted in 2B. And that is to increase the hours from 20 to 22 hours as a condition to renew the expanded authority, and to clarify that in addition to the 2 hours of infection control, 2 hours must be in animal welfare training, and to strike the word diagnosis and replace with evaluation. And then finally, the authorization section. and I don't know exactly where this might land, but I will defer to Colleen, is to clarify in section 3B2 and or 3B4, an affirmative statement that a chiropractor who is providing animal chiropractic care is not authorized to diagnose medical conditions of an animal for which treatment is sought. And then add to section 3C, or perhaps a new section, to include the animal welfare reporting requirements pursuant to 7 MRS section 4018, which I've included. And then finally, there was consensus to make the minimum record keeping requirements such that it increases from 3 years to 7 years, which is consistent with other existing record keeping standards. And then finally, the areas for further discussion, as I mentioned before, is specific to the use of a practice agreement versus a referral. What I also heard the Maine Veterinary Medical Association identify is that if the proposal of practice agreement were to move forward, that they would want to make sure that the issue regarding legal and ethical considerations specific to establishing a veterinarian client-patient relationship is considered by the committee. But again, I'm going to defer to those to make that point to the committee specifically. But that was an important component to the discussion about practice agreement versus referral from my perspective. And then finally, section 7 of the report is for me to add my 2 cents, and that is amend a disciplinary section in the chiropractic statute to make clear the board's authority to impose discipline upon a chiropractor who fails to follow the requirements when providing animal chiropractic care. So I'm sure there's a better way to capture that, but the other consideration is for the committee to consider adding statutory requirements to mandate reports to the board within 72 hours of either knowledge of an animal death occurring within 48 hours of receiving animal chiropractic care and or activation of emergency services or transport to another provider during the course of providing care. Part of that is, again, I think from my experience, some of that coordination of care and notification so that the board is aware of the quality of care that is being provided and is informed along those emergency provisions accordingly. And again, it's not to assume that something has been done inappropriately, but it's rather to work more collaboratively when there are instances where patient care needs to be referred out. And again, that's consistent with some other boards, such as the Board of Dental Practice, in which notifications are required to the board when an adverse action occurs.
No.
And then finally, we recommend that any rulemaking be required in consultation with the Maine Board of Veterinary Medicine. I did provide the list of stakeholder participants, and I'm sure I did not capture everybody there, but I think it was a good representation. It was unfortunate that there weren't any licensed chiropractors outside of the board to participate, and noted that Mr. Reed did his best to respond to any practice issues, but I think that was just a known limitation from the get-go. And I'm happy to answer any questions you have of me.
Thank you, Ms. Valancourt. Questions from committee members? Representative Foley?
I don't have a question, but I'd just like to thank Ms. Valancourt for her efforts here. The 3 meetings I attended them, and she did an exceptional job at allowing everybody to have their say, but keeping us on track, which sometimes was a little more difficult, but so I just publicly want to thank you for that effort.
I'm a product of public school teaching training, so that junior high teacher came out a couple of times. Appreciate that.
Thank you. All right. Thank you. What is the will of the committee? Who did you want to hear from?
I think that
Representative Starkey?
I would like to hear from the, both
Both
veterinarians.
stakeholders?
Yeah, I
Okay.
would.
I think you're a representative of the Veterinary Association is online, but Mr. Reed, I think, is here to represent the Chiropractic Association.
Would you like to
Hear
come
from
forward?
others.
Sure. Do you have a specific question or you just want to hear?
Chairperson, members of the committee, thank you for inviting me up. This was unexpected. I think you have my letter. I gave it to Colleen earlier this week. It's been an interesting process. We started almost 2 years ago. And when we came to this outset, we basically asked the MVMA to step to the table with us and tell us how they would feel, how they would help us, and what concerns they would have. Throughout this entire process, we've invited them to help us, to draft laws, to make changes. And throughout the process, we've added those changes to the law as much as we could to make it work. This is a chiropractic bill. Make no mistake, a veterinarian can provide manipulative services to a pet right now, going through the same training a chiropractor does. This bill allows a chiropractor to do it within state law. Many states already allow this in some form. Some states by referral, some states with a business agreement. Many states on their own, they can just do it. Texas, for example, right now has referral, but it has a bill that's allowing them to remove the referral requirement because they found no issues at all. We look forward to resolving this. We do not feel a referral is needed. However, in my letter to you, we give you one last opportunity of a change or a suggestion would be not a referral, but when a chiropractor does see a patient with a pet, we can immediately notify a veterinarian that we're seeing that pet and patient at that time. And that would give the veterinarian notification, and they could call the pet owner and or the chiropractor to say, this is a known pet. We know there are other issues you may not be aware of, or to talk to the pet owner and say, take a breath here, maybe we should look at this together. And I think that's a great meeting place with that and with the business consultative that you have suggested that we want in the law. The law, the only thing in the bill that's missing right now that I'm concerned about is there's no reporting back to the veterinarian in the current law. We had that in the original law. And I think we really want to make sure there is some reporting back required to the veterinarian, regardless of how we go in this. I think it somehow got removed, but there probably should be some reporting back when we do treatment of an animal so they know and they're aware of it later. And I will entertain any questions you have. However, I'm not a chiropractor, so be gentle.
Questions from committee members? Seeing none, thank you for your time.
Thank you.
And I understand there is someone from MVMA. Great, come on forward. Welcome.
Senator Bailey, Representative Matheson, members of the committee. I'm Dr. Casey Cole. I'm the chair of the MVMA's Legislative Committee. I've been involved with Mr. Reed from the get-go of the process. To be honest, there were a few of us that were nervous and a little reluctant to meet the chiropractors. It's been an issue of chiropractors working on pets unlicensed in Maine for a while. We wanted to hear them out, so we heard them out. And we, right from the get-go, said our compromise will be to refer. And we are willing to refer to chiropractors if needed. We want to ensure that animal welfare is maintained in the state. And that is done by veterinarians examining the animal, making sure they don't have any conditions that would be exacerbated by chiropractic care, and making sure that they don't have any infectious conditions that might be spread through the state that might be missed by a chiropractor who's not trained on infectious diseases. That is why we've been pretty insistent about referral. And I'd like to know, referral doesn't mean you have to go right away to your vet and see your vet with the patient. It means if you have a relationship established with a veterinarian, you can call up your vet, explain what's going on with your pet, and they can give you the referral over the phone because you already have that relationship. You don't need to go in and pay for an exam. You just need to already have a relationship with a vet to ensure public safety and animal welfare is maintained in the state. I'm happy to answer any questions.
Questions from committee members? Representative Mastracchio.
Thank you, Madam Chair. So you would support that with the addition of the referral Yes.
Absolutely. That's been our stance from the beginning.
Okay, thank you.
Additional questions from committee members? No, seeing none. Oh, yes, Representative Barford?
What? Yeah, I'm just curious because this was part of conversation in the beginning. What if it was an area where it was a veterinarian desert and there simply weren't veterinarians to go to get the referral to go see a chiropractor? And the owners were fully convinced that that was in the best interest of their animal to take them to the chiropractor. How would you address that situation?
I would say a place that has a veterinarian desert is probably gonna have a chiropractor desert too. I mean, you saw the numbers, there's more veterinarians in the state than chiropractors, and there's only 2 chiropractors going into this right now. And a chiropractor is not a replacement for a veterinarian. I would also say I've seen a pet come in for my clinic for back pain just a few weeks ago, and I had a bleeding splenic mass. So the clients thought I had back pain. I looked at it and I found something that needed to be going to surgery that day. So I know veterinarian deserts exist in Maine. I want to solve that. If this committee wants, if people on this committee want to solve that too, reach out to me, reach out to the organization and VMA. We have solutions we would like to discuss at some point to solve the veterinarian desert issue, but I don't think this bill should be a replacement for that.
Thank you.
Thank you.
Representative Olson?
Thank you, Madam Chair. How long typically does it take to do the referral?
I mean, it can be over the phone. If you have established a relationship with a veterinarian, you can call your veterinarian up, talk about the symptoms, and if they think it's necessary or safe to do, they can give the referral over the phone.
So you'd have no problem with inserting language in there. The referral must be done within 24 hours of first contact.
Yeah.
You.
Yeah, or if like, exams required, like if what you're describing sounds more complicated than just pain that would be solved by a chiropractor, they might recommend an exam first, but yes.
Representative Foil?
Maybe I should wait because I guess I don't have a question. I have a thought in
Okay.
response to what Representative Olson.
Any further questions? Thank you very much for your time.
Thank you.
Appreciate it. What is the will of the committee? Representative Boyle?
I think this is where I continue to get stuck on the referral is I could see a good vet saying, well, like you haven't been in a year or you're overdue on this vaccine. And so I don't want to give you the referral for this issue until you come in for these other issues. And that's, as a pet owner, that's where I get stuck with the referral piece.
Representative Mastrocchio?
Thank you, Madam Chair. I guess I don't, because chiropractic care is not a replacement for the care of your animal. First of all, I don't see that as, and I do see that sometimes humans use chiropractic care because they, well, I have this backache, let me go see if the chiropractor works. And that might work with somebody that can talk. But when you have an animal that can't talk to you, that sometimes I think that as an animal owner, as a dog owner, well, they talk, but their own way. Right. My dog definitely talks. I guess I feel like that referral piece for me is kind of important. I think that what we've talked about today and the training and everything that would be encompassed here, but I really think that referral piece, I'm not comfortable yet eliminating that totally, but I would like to be able to explore how we could put that in a way that everybody would be comfortable with, because I do think it's an important piece.
Representative Clucci?
Yeah, so I'm having a hard time understanding why this is something that we need or even need to be considering. It seems like we have, there's so few chiropractors interested in this, and I just sort of wonder, if the vets can provide this service, then I'm not sure I understand why we would create a pathway for people that aren't trained to work with animals to provide a service that vets are capable of performing. And my understanding, I think, was that we have 23 vets in the state that can provide the chiropractic care. And then then I also have a question that something that Ms. Valancourt had said in her report, that there's a potential harm to animals if this is not regulated. But if it's not regulated, chiropractors shouldn't be doing this work. And so there shouldn't be complaints coming they should be saying no because I'm not licensed to do this work. So I don't see that there is a potential harm to animals by not passing this. So I'm really struggling. If somebody can help explain to me why there's a need for this, I'll entertain it. But right now I have a really hard time with it.
Representative Foley?
Thank you for that question. The reason the bill is here is because it is happening and it's unregulated. And this puts regulations in place for those that choose to do it or choose to do it in the future. I mean, the one statement you made that says people who aren't trained to take care of pets shouldn't be doing it. Well, they are trained. They have to be certified. There's a certification process that this bill requires them to get certified through the different associations that are out there. You know, there's training involved. There's a number of hours of training that are involved. So it's not just somebody walking off the street and saying, I'm going to start treating pets. They are trained. They're trained to do it. I think the issue of the referral is problematic. It's been between the two groups. The concern I've expressed regarding that is not everybody, whether it's right or wrong, has a veterinarian. They get the dog or the cat or whatever, they get the first shots and that's it, they're done. Whether it's right or wrong, I'm not judging that. I'm just saying they don't. And so our bill would sort of say, well, if you want to treat your pet with a chiropractor, now you have to have that relationship. So that's why, I originally had talked about, having sort of a collaborative agreement between a chiropractor and a veterinarian and say, hey, I've got this animal. These are the symptoms that I'm finding. I'm thinking about doing this, but what do you think? And then let that consultation drive whether the veterinarian says, well, it sounds to me more like Lyme's disease than, so I would prefer that we do the test. Let's find out what's going on. And I think that would happen. I would agree. I don't think, I'm not even ready to vote on this bill today. I think that there is a broader discussion to be had about how we accomplish that and do it in a way that meets both the pet's needs, the pet owner's needs, and the profession. So I think that's a fruitful discussion to have amongst ourselves, amongst the two groups, to try to just delve in. I mean, we dealt with a lot of this stuff. We tried to get, and I think we've resolved most of those issues. So I think really here's the one issue. And how do we craft that so that both sides can be comfortable with how that moves forward? So that's sort of the place I'm at.
Senator Bailey?
Thank you, Madam Chair. So I'm just wondering, when struggling with these issues, if it came up in any of your discussions, what's the difference in cost between having a manipulation with a chiropractor for your dog and going to the vet and having that happen? Did that come up?
We did not discuss those. I don't recall that.
I would like to. Okay, I would like to have a sense of that. And I don't need proprietary information, but I'm assuming it's cheaper to go to a chiropractor than the veterinarian, but that's an assumption. So if we could get that information, that'd be great.
Representative Mastrocchio?
Thank you, Madam Chair. But you'd also then have to look at, we have veterinarians providing chiropractic care. So that would.
That's what she's talking about.
Okay, well, but how much does that mean? Well, it's interesting because we know that people are doing it now, chiropractors who are not licensed, and are they charging for it, or are they just admitting that they're doing it? There's nothing that says they can't do it. Right? I'm just wondering if there's any data about that.
Representative Clucci.
So I find this so confusing. If we're like, they're not allowed to do this and they're doing it, that's against the law. So, I mean, I don't find that it's compelling that we should create regulations because somebody's breaking the, like if stealing cars is illegal, should we make regulations about, well, people are stealing cars, so if you're going to steal a car, then, you have to do this and this and this in order. I mean, that to me I don't find it to be compelling. I feel like the reason why it's not happening is because I don't think that we should be doing this based on that. I think we should be thinking about safety and looking out for, being the public advocate, because I think that's important.
Just 1 second. I just want to clarify in this report, there was some real agreement and consensus on allowing chiropractors to do this, correct? Between the veterinarians and the chiropractors. That's my understanding of what we heard.
Well,
But there's the outstanding thing is the referral.
Yes.
But there's real agreement that chiropractors can be trained to do this service.
There was agreement that if
Okay.
all these other, changes were made to the bill about the, the
Education.
education and
time.
those requirements,
Yep.
and there was a requirement for a referral, then my understanding is the
Okay.
veterinarian association would be comfortable with it.
That's what I
moving
understood.
forward.
Okay, I just wanted to make sure I was
Yeah.
not hearing that incorrectly. Representative Mastracchio, did you have?
Google's a wonderful thing, and AI, because it does say that common costs for chiropractic veterinary care are depends on, for a horse, $100 to $250 per session. Initial evaluations, 95 to 150 for other animals, smaller animals, follow-ups, package deals. Clearly, there's, it's all out there. Then there's travel fees if you have to go to the farm. I mean, it's not cheap. Let's put it that way. Like anything, like dogs and animals cost a lot of money. I don't care where you go with them. It is very interesting information on here, though, for sure.
Thank you, Representative. Additional discussions? Representative Clucci?
Okay, thank you. I mean, my understanding is why the reason why that referral piece is important is because the people that are trained for years and years on how to take care of animals want to ensure that the people that are, if they are going to do this, are competent to do it. And so I'm not sure, I mean, to me, that seems like clear. We want to make sure that people are, because they haven't had years and years of experience. They've had 210 hours of training and a practicum. I don't like this.
Thank you. Representative Arford?
Thank you very much. And I am very grateful for all the people that have done so much work on this. It does strike me in the report that we received that currently there are 9 states that have adopted direct access legislation, and 25 more are in process with it. And 13 other states allow it through referral or under supervision. So this is problematic that there's no industry standard that we can fall back on. And, the reality is that it will be more expensive if the referral is required, because in addition to even though I'm not saying I don't support that, I'm just saying if we're thinking about cost, because cost could put it out of the reach of a lot of animal owners, how much this service will cost them. And so if they have to pay a veterinarian fee for some sort of an assessment and then a referral on top of the fee to the chiropractor for the service, I mean, potentially, we're creating a scenario where only people that are well-resourced are going to be able to afford this service anyhow. So I'm not sure where to go with this, but I do appreciate all the information we've been given.
Representative Olson, he hasn't spoken yet.
From my understanding of it, if what I heard earlier was correct, it's not necessary that they would have to go to the vet first. That something could be done over the phone. It'd be a call that says, here's the symptoms, here's what it is. Do you think quiet chiropractic is appropriate? And then they would do the referral. At that point, they could also say, no, we don't think so. You should come in here. But so you wouldn't necessarily, and if you're established with that vet and they're doing, they're looking out for the better health of the animal, they probably are not going to charge you for that phone call. It's only if they say, wait a minute, all bets are off. You really need to bring them in, bring them into here first. Then you're going to have the vet visit. That would be my understanding of what was just said a few minutes ago, or 20 minutes ago.
Thank you, Representatives. Senator Bailey.
Thank you, Madam Chair. I just wanted to point out, Representative Clucci, I know you don't like the bill. It doesn't matter. And I'm not saying this to convince you of anything, but my understanding of why the veterinarians were insisting on a referral was not about checking the qualifications, because they've already agreed to what the qualifications could be. They know these chiropractors are certified, and that's not what it's about. It's about ensuring that this particular animal is in a situation that chiropractic care would not be harmful. So that's why they want to do the referral, is to make sure that a dog is not going to an animal, I say a dog because that's the animal I have. An animal is not going to be receiving chiropractic care when it's contraindicated. Is that the word? Okay. So just to clarify that, it's not about making sure that the people are qualified.
Thank you, Senator. Additional comments? Questions? What's the will of the committee? Representative Foley?
Again, I would like to table the bill and see if we can resolve some of these issues that we've heard. And try to resolve some of those concerns. Again, I don't know that there's anything in law that prevents a chiropractor from treating an animal now. They're just not regulated. But that doesn't mean that they don't do it. So I think that, I think some of the standards that are put into the bill with the certification and that is very helpful. But again, we had 3 meetings, a very tight time frame. I think that a little more time might resolve these issues, especially some that we've heard today. And so I think a tabling at this point in time and bringing it back in a couple of weeks
Just
for a
one second.
resolution would be fine.
So before we do a tabling motion, Senator Bailey?
So I just wanted to comment before we table it that what I really ask the stakeholders to really focus on is, again, if we're gonna, I'm leaning towards some sort of referral, but I want to make sure that that referral is as easy and painless, no pun intended, for the pet owner. So whatever we can build in there, and I just want to share the reason I'm leaning towards referral is because I think, like so many of these things that we've seen in other areas, you have to start somewhere and build that trust. And that doesn't mean that, you don't build away from referrals in the future. But I think where we've never done this before, that it makes sense to start out that way. But again, to make sure that those referrals, that we're not making people have to incur more vet bills just to get this referral. So I take them at their word that they want to make it easy, that hopefully you can just pick up the phone and get them. So just letting the stakeholders know what I'm thinking. Thank you.
Representative Clucci?
So just as we're considering trying to make a referral process as easy as possible, earlier today we spent a while talking about practice agreements that are basically just a way for companies to make money that provide no actual value. And so I would encourage you to think about, if you were going to go in this direction, how do you make it so that you don't just have a vet set up, oh yeah, just call me and I'll give you the referral, but you have to pay me X amount of dollars a month. I mean, I think that's
It's reasonable.
So because I think that's exactly where we would go. And then in 4 years, we would get rid of it altogether and just slowly make it less regulated.
Representative Barford?
Everybody's making good points and we're seeing I'm going to focus on the best part of these two industries, both veterinarian and chiropractic. And yes, it could head south. It could turn into a profit making if we were to pass this bill and require the referral, or it could go in the exact opposite direction. But no matter what, I'm quite sure if we were to pass this bill, then in a couple of years, one or end or the other are going to come back to us and ask us to do something more. Like either ask us to, since they're so well established, allow it to go forward without a referral. The chiropractors might come back and ask us. So I don't think no matter what we do today, whether we table it or pass it, it's not the end of the story. We will be hearing more in the future. And so I have to say, there's been so much work done on this. I do support a tabling motion, but I also do tend to support this bill as well.
Thank you. Additional discussion? Do I have a motion?
I move the table.
I'll second that. We have a tabling motion and there's no discussion after that. So we will end the work session. Oh, right. Oh, yeah, we do have to vote. Sorry. Bob said table. Show of hands. Show of hands. Yep. Okay. Great. Thank you so much. We will close that. Yes, absolutely.
I just would like to encourage Ms. Valancourt and the members to take what they've heard today and let's resolve this so that we can come back in 2 weeks to come up with a resolution. So thank you.
1 or 2 weeks, yeah. Preferably 1. All right, so we're going to open up the work session for LD 2128. Colleen.
Okay, so I think you have the analysis already in your folders for this one. This is a department bill. It was submitted by Department of Public Safety, Maine Emergency Medical Services. As I understand it, it's based on recommendations that were made by the Blueberry Commission to study emergency medical services in the state. It seeks to continue to restructure the functions, the structure and functions of the Emergency Medical Services Board. Section 1 of the bill reduces the number of members appointed to the Emergency Medical Services Board, other than members that represent regional councils, from 12 to 5. It also provides that each of the 4 regional councils is responsible for appointing a member to represent that region. Makes it clear also that the commissioner of the Department of Public Safety or the commissioner's designee is an ex officio non-voting member of the board. Section 2 requires that the governor or the regional council respectively must appoint a member to fill any vacancy for an unexpired term. Section 3 clarifies that the board shall meet at the request of 5 members at 5 members. Under current law, the board shall meet at the request of 7 members. So it just reflects the reduction in the number of board members. Section 4 would require the board to report annually by January 1st to the Committee of Jurisdiction over emergency medical services matters, any recommended changes to the Maine Emergency Medical Services Act and other necessary changes to improve emergency medical services, and allows the committee to report out legislation based on the board's recommendations. Section 5 is a provision that relates to the regional councils. It requires them to, at a minimum, to provide adequate representation for ambulance services and non-transporting emergency medical services, emergency medical dispatch centers and emergency medical dispatchers, emergency medical services training centers, and the general public on the regional councils. Section 6 directs each regional council to appoint a candidate for a position on the Maine Emergency Medical Services Board. Section 7 just makes a change in grammar. Section 8 requires regional councils to regularly advise the representative to the board on issues, concerns, and policies affecting that region. Section 9 authorizes a member of the Emergency Medical Services Board serving on the effective date of this act to continue to serve till the expiration of that member's term. And there are some current vacancies that will allow that to move forward. As drafted, the bill reduces the total number of board members from 16 to 9. Currently, there are 4 members representing each regional council selected by the governor based on nominations from the regional council and 12 additional members appointed by the governor. The bill reduces the number of members appointed by the governor from 12 to 5 and changes the statutory requirements for those appointments as follows. So the regional councils will appoint their representatives rather than making a suggestion, providing names to the governor to select those representatives. And then it reduces the representation, the representatives appointed by the governor from 12 to 5. So it's just a comparison of the 12 members under current law and the proposal in LD 2028. So the 5 members, if the bill moves forward, that would be appointed by the governor. There would be 1 representative of an emergency medical dispatch center or emergency medical dispatch provider, a representative of a municipal, and the testimony suggested that should be clarified to say municipal fire department administration. So that's one suggested amendment. A representative of emergency medical services administrators, an emergency medical services paramedic licensed in the state, and an emergency medical technician or advanced emergency medical technician licensed in the state. There was legislation enacted in the first regular session that became law, Public Law 2025, Chapter 491. That was a bill that was considered by the Criminal Justice and Public Safety Committee, but that implemented sort of the first phase of the restructuring and established a separate 7-member licensing board appointed by the Maine Emergency Medical Services Board that would be responsible for investigating complaints and imposing discipline on licensees. So that's attached for you for your information. And my understanding is under the restructuring that's envisioned, that was envisioned by the Blue Ribbon Commission's recommendation, there would be a separate licensing board appointed by the Emergency Medical Services Board. And then this 5-member, 9-member board now would be focused on sort of the oversight recommendations related to policies and the like, and sort of separating out those 2 functions. So a separate licensing board that would be appointed to oversee things.
Could you clarify that just a little bit more? I'm sorry. I'm not sure I understand the difference between those 2.
So,
Like, or just give me an example of what would, like, someone who had a complaint about EMS would go to the 9?
that would go to the licensing board that was enacted last session. And under that structure, the members of the licensing board would be appointed by the members of the Maine EMS board that this bill does. So that's the idea of sort of,
thank you.
as I understand it, sort of parsing out those functions separately. And then finally, I would just raise for you, although it's not addressed in the bill, we've talked about this before, but there is a provision in the Maine Emergency Medical Services Act that is scheduled for repeal December 31 of 2026. And this might be an opportunity for the committee to address whether or not you're comfortable with having that statutory repeal go forward. It's a provision in Title 32, Section 86, subsection 1. It relates to the board's a directive to the board to adopt rules and protocols to evaluate the need for any new ambulance service in the state before granting a license under this subsection. That paragraph A, you'll see the language there, is scheduled to be repealed December 31 of 2026. So it was when it was first put in place, there was a sunset on it. So this would be an opportunity for the legislature to take affirmative action to continue that language in statute. And if you did so, it would continue. If you did not, it would be repealed as of December 31. But I just wanted to make you aware of it. I did reach out to the Maine EMS. My understanding is they don't have a specific position on the provision. But if the statutory authority were removed, they would, they believe they would have to revise any rules that they have pursuant to that statutory authority to reflect that they would no longer have the authority.
This is
to
kind of
do
like
so.
a certificate of need for EMS. A mini
Yeah,
tiny
in this
one.
narrow function. My understanding in the feedback I did get from Maine EMS is the extent to which they have sort of done an evaluation of a need for ambulance services. They haven't denied one.
Got it.
To this point, so.
That makes sense.
Yeah.
Representative Mastracchio.
Thank you, Madam Chair. So the paragraph that's repealed is A?
Just A, so subsection.
Oh,
one
okay.
was
That's
A.
what I just wanted to make
Yeah.
sure that subset.
Yeah,
Okay.
just A.
Just want to make
So
sure I.
It would still, the requirement in statute that ambulance services and non-transporting emergency medical services must be licensed, operate in
Okay.
accordance with rules of the board. It just would repeal the specific, the board shall adopt rules to evaluate the need for any new ambulance service. That would go away unless the legislature, you could add to this bill an amendment that would strike out that last sentence there. This paragraph is repealed if you wanted to keep it in statute or not. But you won't have another opportunity to
Senator Bayless.
So I'm still confused though. If they've adopted the rules, then why do we need to keep that paragraph in statute?
I don't necessarily think that you do need to keep it in statute. They can provide you with their analysis, but my understanding is they have been advised that if that goes away, they would have to repeal their rule
Their adopted rules.
because they would no longer have the statutory authority to have a rule that addresses the need for any new ambulance service.
Really?
That was the feedback I got. I think I don't know, do you have representatives here to speak on that? Yeah. Yeah. I mean, my initial thinking was you have general rulemaking authority that may cover the
Right.
scope of this. So if this went away, it may not necessarily mean you need to repeal it, but that was part of the feedback I got from it.
Got it. Senator Bailey, yep.
So why was the sunset put on there? I mean, I'm assuming the sunset was put on there because the committee thought this is how long you need to make these rules, and once the rules are adopted, this can go away, but I'm hoping I wasn't on the committee when this.
No, and it
but
wasn't,
might have been.
didn't come out of this committee, but
Okay.
yeah. Yes, I mean, the other option would be, you could amend subsection 1 to say, in accordance with rules adopted, related to the evaluation of a need for new services and let paragraph A go away. And then they would have the authority, then they would have something to point to for their authority to maintain the provision in the statute. And the provision in the rule. I guess they can provide you with their assessment, but as to whether or not it needs to continue in law. I think from my understanding is they haven't denied any, so maybe there's
No need for.
no
it.
need to continue to evaluate them. I'm not sure if that's the thinking or not.
I'm wondering why it was put into statute, the need to evaluate. Was that because maybe services were not going to areas that needed the service, or honestly, I just don't really understand.
Yeah, I mean, I think in part it was part of sort of, there was a lot of work being done on, a lot of attention being paid to emergency medical services at the time, and maybe making sure that there wasn't kind of like a certificate, a duplication of services or, that sort of thing. Perhaps that was why the evaluation was put in place. I'm not sure.
Representative Olson?
Hasn't been
Maybe
instant.
we'd have to look at the dates on there, but in my recollection, back quite a number of years ago, we went through a whole spat there where you had at least eight or 10 ambulance services that went bankrupt. So maybe it was an effort to try and keep an eye on growth there so that you made sure that if a service started, it could, be able to survive. If, as I say, if my memory is that, it was about 8 or 9 years ago, there was a bunch that went bankrupt.
Right. Senator Bailey?
Thank you, Madam Chair. Just another clarifying question, Colleen, on section 4, paragraph M, the reporting back.
Yep.
So do we know who the Joint Standing Committee of the Legislature having jurisdiction over EMS is?
It's criminal justice. and
Right
public
now, there's
safety, right?
overlap.
I
Yeah,
know.
right.
Between this committee and the Criminal Justice and
Justice.
Public Safety Committee. I think generally, this committee has been responsible for licensing of EMS services. I would say general EMS services in the past few legislative sessions some have been referred to us, some have been referred to the Criminal Justice and Public Safety Committee. And I guess this bill is one example. They had the bill last year that related to establishing the licensing board that oversaw complaints. This year, the structuring of the rest of it came to us. So there's definite overlap. And that could be something where the committee could be more specific. Sometimes we refer to, we sort of use the name of the committee itself. Sometimes we refer to the general matters, like a joint standing committee having jurisdiction over appropriations. It's more aligned to the actual name of the committee as opposed to the functions of the policies that the committee oversees. But yeah.
Senator Bailey, yep.
Yeah, I mean, what I'm thinking is I would want it to go to both
Yeah,
committees so
that's
that
good.
they're both kept up to date. So
Yeah.
I'm not sure how to word that. But the way this is written, it's talking about a committee.
Yep.
And again,
Yeah, similar, like when we talked, we're going to be reviewing the bill on this guarantee, loan guarantee program. And that legislation, you'll remember, had a provision in there that would allow the reporting out of legislation to address funding needs. And it talked about both committees, AFA and this committee. So we definitely, if you wanted to broaden that, we could amend that language to include both committees. Yeah.
Great. Additional discussions? What is the will of the committee? Do I have a motion?
sure.
Senator Bailey?
Thank you, Madam Chair. So I do motion ought to pass as amended, adding the fire department before administration that we talked about, and then just clarifying in the paragraph M to include both CJPS and HCIFS on the report back.
Second.
I have a second. We have a motion. Is there a discussion?
Just trying to get from what had been discussed.
So the motion on the floor is to ought to pass as amended, adding in fire department tier and clarifying that the report back would come back to HCIFS and criminal justice and public safety. Okay. That's the motion on the floor. Did you need any other update than that? Okay. So we have a motion on the floor ought to pass. No more discussion. I think we're ready for the vote.
Senator Bailey.
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Alford?
Yes.
Representative Alford, yes. Senator Baldacci?
Yes.
Senator Baldacci, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Clucci?
Yes.
Representative Clucci, yes. Representative Flynn?
Yes.
Representative Flynn, yes. Representative Foley?
Yes.
Representative Foley, yes. Representative Strachio?
Yes.
Representative Strachio, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Olson?
Yes.
Representative Olson, yes. 11 members of the committee having voted in the affirmative and 0 in the negative.
Good. Okay, great. So we will close the hearing for LD 2128 and open up the hearing for LD 2133.
Great. This is another bill submitted by Maine EMS. This one makes a number of changes related to licensing of community paramedicine services and clinicians. Section 1 of the bill updates the existing provision in law that provides an exemption from licensure for community paramedicine services as a home health agency. Section 2 updates a cross-reference. Sections 3, 8, and 9 of the bill require community paramedicine clinicians and community paramedicine services to be licensed by the Maine EMS board and establishes minimum requirements for licensure. These sections also direct the board to adopt rules that would govern the qualifications and standards of licensure. Sections 4, 5, and 6 define community paramedicine clinician, and community paramedicine service. And those definitions are in the italicized language there. Section 7 repeals language in existing law related to the EMS board's authority to adopt rules for community paramedicine. They would be replaced by language in the bill. As I mentioned, the bill repeals and replaces current law related to the board's authority to adopt rules for community paramedicine. The current law is attached for you. The specific provision that's being repealed is subsection 4, which is on page 4 of the analysis. And so this would be, it authorizes the board to establish community paramedicine services and establish the requirements by rule. This bill puts in place statutory requirements and then would give the board additional rulemaking authority with regard to licensing. Under current law, as I mentioned, with regard to section 1 of the bill, and I neglected to attach another copy of the amendment, but it's on the buff colored sheet that was submitted at the public hearing. Ambulance services and non-transporting emergency medical services that are authorized by the board to provide community paramedicine services are not required to be licensed as home health agencies. As drafted, LD 2133 maintains that exemption from licensure for community paramedicine services. In testimony, Maine EMS suggested that the bill be amended in section 1 to maintain the language that requires community paramedicine services to be episodic in order to qualify for an exemption from licensure. And this amendment was requested by the Department of Health and Human Services. So the amendment on the buff colored sheet just would maintain in statute paragraph A of the current law, which if you look at the bill in section 1 would be stricken through. So just seeks to maintain that provision. You did have some written testimony that was submitted by the Maine State Nurses Association expressing some concern about potential patient safety risks that could arise under the bill when community paramedicine substitutes care by paramedics for the expertise of registered nurses. They noted that the distinction between community paramedicine and home health services and when each is appropriate has been raised as a concern during previous stakeholder discussions about community paramedicine. And I think the section 1 tries to make that distinction. And I think the amendment, that's been suggested would go further in terms of trying to clarify the distinction of, the types of services that can be provided through community paramedicine services and the types of services that might be provided by other providers through home health or other activities. You also had some written testimony from Representative Eaton that I didn't know if committee members had seen, so I noted that for you. Her testimony asked the committee to consider the potential impact of the regulatory changes on existing community paramedicine programs, particularly those in rural and island settings, and suggested that these programs need flexibility to continue serving patients without unintended disruption. So, this does put in place a requirement for licensing, for community paramedicine services. So just consider the potential that new regulatory framework might have in terms of resources, time, money, because there'll be a licensing fee, that type of thing. And as I mentioned, sections 8 and 9 of the bill would authorize the board to adopt rules related to the licensing of community paramedicine clinicians and community paramedicine services. The rules in the bill are designated as routine technical. The committee, as always, would have an opportunity, if you wanted to see those rules, designate them as major substantive if you wanted final legislative approval before they moved forward. That does impact the timing and when they can be adopted, though, just as I'm sure you're aware. The language in the legislation does sort of establish in statute minimum sort of licensing standards, and then that would have to be followed in the rule, and then the board could through their rules, do something additional as long as it was consistent with the statute. I did also want to note that following the public hearing, I did have a communication from Maine EMS that perhaps there needs to be an additional definition considered by the committee of EMS instructor. So I wanted to note that. I don't know if they have any suggested language for the committee to consider. I haven't seen that yet. But there was a preliminary fiscal note that the Department of Health and Human Services did indicate to OFPR that if the legislation moved forward as drafted, they may need additional funding for part-time position to handle anticipated complaints of unlicensed home health providers. As I understand it, the suggested amendment to section 1 of the bill, if that is made, the department no longer believes the fiscal note will be necessary because it just provides the clarification that they need with regard to the licensing exemption. So I'll stop there and I'm happy to answer any questions that you have.
Questions from committee members? Representative Clucci.
Thank you, Madam Chair. Colleen, this question's about, I think probably it's about the existing statute. I'm just hoping you can help me understand a little bit more. In section 2, it says that a carrier may require an ambulance service provider to obtain prior authorization providing services through community paramedicine. So does that sort of imply that in order to have community paramedicine, you would actually need to have like sort of a sophisticated setup where you are taking insurance and you're getting approvals and, or like, I'm just wondering, does this sort of rule out the ability for small towns to be able to provide this service?
So that is the existing statute, but the committee has talked about enacting a mandated benefit for community paramedicine services. And to date, the committee has not moved forward with legislation to do that. So this paragraph in the statute reflects that. So you know that under the current law, which we've talked about previously when you talked about LD 1530, there are specific requirements for reimbursement rates for ambulance services and now non-transporting ambulance services. And that section of statute included language when it was first enacted, and then first some additional amendments were made to carve out and say that it would not require a carrier to reimburse ambulance services at the reimbursement rates that are specified for covered services that would be delivered through community paramedicine, because the committee wasn't ready to sort of expand the scope of that statute at that time for community paramedicine services. And also wanted to preserve the ability of carriers that to require prior authorization for, if they chose to reimburse for community paramedicine, they could follow their existing requirements for prior authorization. So that's what the current law says. The section 2 of the bill just simply corrects the cross-reference, because now we're enacting a new section of law that would license community paramedicine. So it used to be section 84 subsection 4. Now it's going to be a new section 85D that defines what community paramedicine services are and the licensed providers are.
Senator Bailey.
To try to answer that question more, I think that obviously
community would have to decide whether it was worth it for them to try to set up a internal structure for getting reimbursed by insurance, and some do and some don't. Some don't bother. You know, is it worth it?
Yeah.
Yeah, you know, fiscally, is it worth it? Because like you say, you know, there's paperwork involved, right? So, but they don't have to. This doesn't, you know, say you have to accept insurance if you have community paramedicine.
And I'll throw another wrinkle in this, but there's a bill in the Health and Human Services Committee that was heard today, actually, that would require reimbursement under Maine Care and Title 24A for community paramedicine services, which you have discovered in the past and not moved forward with. So that's a separate thing, but the requirement for reimbursement for community paramedicine services, I think, is a continuing one that the legislature will have. This bill addresses the licensing piece of it.
Yeah, and licensing helps with that, with identifying whether or not a provider can be reimbursed. Did you?
Just step up.
Oh, the first
Sorry.
step up.
Representative.
Thank you, Madam Chair. And sorry, I'm just like looking at Representative Eaton's letter and looking at this. So I'm guessing some of the things that she may be referring to as these additional like background check requirements and just sort of the licensing requirements in general.
I think so. I don't think her letter wasn't specific, but that's what I think she was speaking to, like the impact of these additional requirements, you know, what they might have, you know, what they might mean for smaller entities that are doing some version of this now. And now, if the law moves forward, they may need to be licensed and meet these requirements. Yeah.
Representative Clucci?
Okay, thank you, Madam Chair. So, so trying to understand, so with community paramedicine versus non-transporting care, we've made it possible to bill for the non-transporting care, or like that's the bill that we passed. And so if you're set up to do billing, you could do that. With community paramedicine, if we're sort of creating the structure so that you can bill, does this, I guess I'm trying to figure out, does this preclude, will the steps that were taken in this bill preclude a community from just setting up a community paramedicine program and sort of funding it itself? And like, so you could do the work. So you could potentially do the work and just not sort of request for reimbursement for it.
You wouldn't be required to get reimbursement, but where it would potentially affect a small town are the licensing requirements.
If you wanted to
and the
set it up, I think
regulatory.
you would have to meet the licensing requirements potentially.
Right, okay.
Yep.
So I have some other questions, but I can wait.
Additional questions? Go right ahead.
Okay.
Representative Clucci.
Okay, so in reading through this, it looks like in order to set up a community paramedicine in a community, you're going to have sort of set up a service in addition to having your clinicians licensed. So the service then requires that you have a primary care medical director, and then an EMS medical director. So I'm trying to understand, do they have to be paid, or is it just sort of like one of these consulting or agreements we've been talking about all day, just like collaborative agreements? What does that look like? And how, and maybe we can hear from the EMS board about like how much they expect setting up a structure like this to cost. Because I do worry that, you know, like at Bodenham, the paramedics were folks were trained on community paramedicine, and then they were told that no, we're putting in new trainings, and so now all trainings, you have to retake your trainings for community paramedicine. They have to go through this one group, and there's all these other things that are going to be sort of put into place, right? So I'm just wondering, how much is this do we have a ballpark of what is this gonna cost? How is this gonna work? And are small communities like mine going to be able to offer something like this?
So did you want to bring up?
Yeah, can we bring up Mr. O'Neill?
Sure.
Thanks.
I did want to indicate that I also have my subject matter expert, our community paramedicine coordinator, Sylviana Goldrich, is with me as well today. So. I think kind of to get to the heart of your question, I'd like to back up just a little bit. So EMS services to do community paramedicine, I already have to be an EMT. I'm already licensed and I'm affiliated with the service. What we're trying to achieve partially through this bill is to make sure that some things that we've seen in other states where they lack regulation don't occur in our state, which is a third-party agency comes into your town and says, well, now we're the community paramedicine provider here. And they don't have to affiliate with your agency and they don't have to have regulation with us. And then they just start doing, as you said, the business of community paramedicine under some billing structure that they invent. That's already happened in states where we've seen like Utah, where they didn't really have a clear way to regulate it. And folks walked in and said, do you regulate this? And they said, no. And immediately there was a proliferation of businesses there. So this kind of does two things. It helps protect communities because as a community paramedicine business moves into your sector, they should be a part of or affiliated with your EMS agencies or fire department because they're working in tandem with your entire healthcare ecosystem. So that's the first part of that. The requirements are not meant to be onerous. There isn't currently a licensing fee for a community paramedicine license. And in fact, Maine is somewhere around 48 or 49th in the nation for what we charge for licensing fees because we really want to make it affordable. That said, background checks matter, right? To be an EMT, you're going to have to get a background check, but as part of community paramedicine and our home health obligations, we made sure that background check as part of this as well. The only fee related to background check is a $21 fee, and it's a pass-through that we give to SBI to do the background check for us. And again, that's really just to make sure that these folks are safe. The level that a community paramedicine technician has access to a patient is uniquely different than our regular EMS crew on a pre-hospital call. And so with that in mind, we really looked at these standards. But we think about our island communities and we think about our small communities as well. We're not looking to put an onerous burden on them. We want to keep them safe and find them a way to get paid for businesses that are essential to their communities, many of which they're doing right now for either grant funding or in ways that are unpaid or in very creative ways where they're trying to shift money around to provide a service that should be clearly defined and paid for by insurance. Thank you.
Thank you. So, the primary care medical director and the EMS medical director, who are the people that fill those jobs? Because do they have to be a DO or a MD? Do they have to be paid for by the town to be affiliated with the town? Or are they the volunteer head EMT with the volunteer fire and rescue at Bodenham?
With some direction, we actually give them quite a bit of variability. In Maine, we don't restrict medical direction to EMS agencies to just physicians because we know they can be hard to find. Additionally, the way that that's set up is primary care is a key component of effective community paramedicine, right? Like when you go to the hospital for care and then get discharged, you want your primary care physician that sees you the most to be able to follow up that care that's going to keep you from getting back into the hospital, which is where we provide some of the most value. And so that need for a primary care medical director is written in. That person could be a volunteer. It could also be the medical director that you already have that has that primary care expertise, or it could be through some partnership. But we've kind of allowed it to be as broad and variant as possible. We're still requiring it because it's such an essential part of the differences between those two styles of medicine. Taking care of a person in their home episodically is uniquely different than the pre-hospital environment in our regular medical direction.
Representative Clucci?
Is this I'm trying to the medical director. Like, does the town need to pay for a medical director to have community paramedicine in the town? Because you're saying it needs to be sort of linked to the municipality. None of my towns pay for like a medical director that I'm aware of.
Your EMS service that is licensed through Maine EMS has a medical director.
And that person can serve as the primary care medical director and the EMS medical director?
Potentially. We're looking at trying to make this as broad as possible, and it comes down to their expertise. For most EMS medical directors, they're going to be on the emergency medical side. So they prefer a partnership with somebody in primary care. For a lot of physicians, they've worked in urgent care settings and done primary care as well as emergency. So we really tried to kind of leave that broad. So it's easy to find someone that can fill that role, but it is a necessity to kind of have that partnership as we saw.
Representative Harper?
Thank you, Madam Chair. So am I correct in thinking that you'd have one individual serve as your medical director for the entire area that you're servicing? And or would this be someone that would be embedded in the community, or is there great flexibility with, how does it work?
So there is great flexibility and it's somewhat designed, or it will be somewhat dependent on how your system is designed. So if I'm town A and I use ambulance service A as my EMS service, and now they're going to provide community paramedicine service A, they may or may not have that primary care connection yet. They'll need to get that to provide the other layer of service, but then that's what they'll need. They have the pieces there all together because your agency is already licensed through us and has medical direction. We have now, I feel like for the amount of work we've done, this is way too light to carry around. Right? Like we put curriculum and standards in place for community paramedicine. We went through a huge project to get this to where it's licensed. And so what we're looking for is really those formal definitions that help move us into the realm where we can seek reimbursement through the formal frameworks. So the pieces I believe already exist, kind of to answer your question very specifically. It's just about, okay, when we decide we want to start doing this service, if it's new to us and we're not already doing it, because we have over 20 communities already doing it, they will need to establish that relationship if they don't have it. But again, it could be just a voluntary relationship or something for a small fee. It really depends. What we've seen, and I think what most folks you've heard from would echo, is there's a great thirst throughout our communities to be able to provide these services and have them reimbursed because they keep people out of the hospital, they prevent readmission, they keep patients happier, and they provide better care at a lower cost. Those are all the things that we really want to meet in terms of our strategic mission. We want to do it as safely as possible. And these medical director connections are the way we do that. Thank you.
Thank you, Representative Boyle.
Thank you, Madam Chair. So I think what I hear you saying, but I just want to confirm, is that you really feel like you took into account these small communities when this was being developed, when the licensing was being developed, and really took into account what's happening there.
In a couple of different ways. One, through our office, our staff, most of which are all clinical providers and work in your communities all over the place in small and large places, but also through our regional advisory committees and then through our board and also through our medical direction and practices board and the community paramedicine committee specifically. So there was a lot of stakeholder input and a lot of conversation as we built this out to be sure that we were listening to the voices on every end. Additionally, we participated in a side project on the Maine EMS and Island Transport Committee, where we heard a lot about how community services really fill an important role on our islands. And so, Maine's a big state. It looks very different. We've got 4 different regions, and even between those regions, there are some significant and unique differences. We're trying to design a regulatory framework that works for everyone, that's cost effective, keeps them safe, and meets those aims of good medicine that can be done for the community and keep them healthy.
Thank you. Additional questions from committee members? Representative Clucci?
Different topic, I swear. So on the minimum licensing requirements for the clinicians, it says under C, the person holds a separate license as an emergency medical services person. So is the community paramedicine a layer on top, or is it full separate track? Like, so if you already have certain tests, does this build on top of it, or do you have to then go and, have a whole separate community paramedicine training?
It builds on top. So a thing that Maine did that I'm very proud of and I think is uniquely different is we're allowed to be a community paramedicine technician at kind of every level. In other areas, they said, hey, you're a paramedic, now you can do community paramedicine. Here we said, well, if you're an EMT, you can do this at the technician level. If you're an AEMT, you can do these skills at the affiliate level. So you get your license, and then now you are qualified for just a set of additional training, including the mandatory reporter training for home health and that. So it's on top of and not as a completely separate track. With the idea being that as an EMT at a service right now, if this is an area of interest and an area of interest to the community, I can operationalize this very quickly.
Thank you. Additional questions? Seeing none, thank you for Representative Arford.
Thank you, Madam Chair. And just very quickly, so like if I was in my community center, I'm in Harpswell, and I start having very serious chest pain, and I call my local provider, emergency medical service provider. They wouldn't, if it was based, it was set up with this community structured program, they wouldn't need, they would make that evaluation once they arrived at my home as to whether or not they would transport, right? That wouldn't need to be made ahead of time, or would it?
Do you mind if I walk that through real quick, just to
Yeah.
illustrate it? So in that scenario where you have a sudden onset of, let's say, non-traumatic
Yeah.
chest pain, right? You call 911 and we send a pre-hospital ambulance crew, and they're going to evaluate you and take you to a hospital. That hospital then, God forbid, finds there's something that they need to look at, and they keep you for a few days, and they say, okay, now discharge, we're going to give you some instructions. It looks like now you maybe have some congestive heart failure, right? A chronic condition that left untreated could degrade your health. So we're going to provide you a referral to a community paramedicine or a community paramedic. They're going to come by your house within 24 to 48 hours after you being discharged in an area where a home healthcare nurse is not available in that time frame, right? Where we're a resource bridge. They're going to come to your house and they're going to do a whole separate set of evaluations and reporting. And that's driven by your physician, right? Because you're discharged from the hospital back to the care of hopefully the new cardiologist and the folks that are taking care of you. And that's where our liaison comes in. So it's an ecosystem, right? That first part gets you the emergency care so that you survive the emergency and get hospital care. The second part helps to ensure that you're following the hospital's directions and that we're doing the healthy things to keep you out of the hospital and follow the directions to get you back to healthy. That serves both the hospital's interests, the insurance companies, and ours in keeping you healthy in the community, yours in keeping you at home. So that's kind of how those two things work in tandem. Is a service that has both would send that out as a referral as a secondary.
So if I could just follow up, but thank you, that really did help. But in addition to that, what if it wasn't an extremely, say I'm just a nervous person, my heart starts hurting, and I've heard all these stories about people having heart attacks. And so you come to that, whoever it is that shows up determines I do not need to be transported, that it's not something that I need to be taken to the hospital for whatever reason they make that decision. Is that when you come into play in a situation like that as well?
No, and I think it's important to understand this. So my experience was as a 911 paramedic working in a metro area of over 1 million people for 12 years. And what I would say is we were given clear direction that I would never tell a patient they didn't need to go to the hospital. What I would do is I would say, based on your condition, if you desire, I could transport you to an emergency room to be evaluated by an emergency physician. Based on the tools I have available, I don't see a life-threatening condition in front of us right now, but I do not have the diagnostic tools to be able to tell you that for certain. We're going to recommend that you see a physician in the hospital. Now, we have even more advanced tools in the field now than we have before. And I can also call a doctor in the hospital and say, hey, I'm here with Representative Arford, and she's had this episode, but she's had it before. She's saying she's very comfortable. She'd like to stay on scene. Her vital signs are doing this and that. And I'm talking now with a physician who's helping us make that decision. It's not your paramedic saying, you don't need to go to the hospital. That's not generally how we're trained to do that now. Certainly anecdotal exceptions might apply, but in my training, in my experience, that's not how we generally.
So you know what, just to make sure I'm getting this. So in other words, the community member would not initiate a visit from the community medicine. It's
From the
always
community
initiated by the referring, the doctor.
There could be situations where, say you have a chronic health condition and you move into a community and you say, hey, I heard the Biddeford Fire Department has a community paramedicine program. I participated one back in Kentucky because they checked my food security or my fall risk, or they helped me keep my medicines updated. And so I'd like to be a part of your community paramedicine program here. That's a way that you might end up kind of getting referred into outside of that loop. We described that be atypical, but I'm just trying to think of any situation. The idea behind this is that we make it as inclusive and accessible to communities as possible for the lowest cost, because it's a lot cheaper to get a clinician out to give you care in your home than to take you somewhere to give you care.
Thank you.
Okay. Further questions? Not seeing any. Thank you very much.
Thank
That
you
was
all very much.
helpful. So further discussion or need for clarification?
What is the committee thinking? Representative Arford.
So I want to make sure I understand the whole, this is a licensing bill. So this
Yes.
is not a payment bill. This is not like who's going to pay the bill.
Correct.
But let's say we pass this and then there, it requires some sort of a coverage mandate or whatever, and for that to be funded, and it's not. So this bill would still go forward as a licensing bill, even if there's no identified payment mechanism.
Correct.
Okay, thank you.
So the only point I would make is because this is new, I would feel more comfortable if the rules were major substantive, at least the first time through, to have them come back. Folks agree with that. So, yeah. Anything else? Representative Clucci, are you satisfied? Or do you feel more clarification? Well, I mean, I was thinking, some of the points that were made, we can clarify those. Like, for example, he said that the primary care medical director and the emergency medical service may be the same person. We can clarify that. So that's what I'm asking you, things like that. If you want, would you feel more comfortable if those were clarified in the statute?
Thank you for asking. Yeah, I think so, because I do, as we noticed earlier today, I think that physician involvement is important. But I also want to make sure that that these are realistically, sort of operationalized programs in the community. So yeah, I think I like the clarifying that they could be the same person, that they could be a volunteer.
And they don't have to be a physician.
And that they don't have to be a physician. Right.
It may be, but.
Yeah.
Could be a nurse practitioner.
It could be a
Or
physician
a
associate.
naturopath.
It could be an independent.
Just kidding.
Physician associate.
No. All right. So, yeah, I think that would, and then I don't know if it makes sense. I just really want to make sure. And I think with Rep Eaton and with sort of what I've said, I think that hopefully the EMS board or whatever you guys call yourselves, there's like multiple organizations. I'm hoping that Mr. O'Neill has heard our concerns that we need to make sure that this is going to be something that small communities can access should they choose to do so. Because I'd hate to have a situation where the only game in town is the for-profit agency that can set this up and can come in and operate it. So, yeah, okay. Thanks.
Okay. Any other?
Only thing there was a suggestion that you need a definition of EMS instructor. Is that something that's necessary? I didn't.
That was something that we would like to hear.
Have them
Sorry.
come back up, please. Yeah. Thank you, Colleen, for remembering that.
Yeah, I just don't know
Thank
if
you
it's
so much.
necessary or not, but.
So in numerous discussions with our EMS committee and nationally, right? We have the National Association of EMS Educators and the National Registry of EMTs. No one had a standardized definition. When we drafted the bill, we were pretty confident that that was defined. It actually wasn't until late last night and early this morning that we saw that there was a potential gap there. So for the committee, what I would request is for that piece in particular, that you direct us to get back with our education committee and specialists, and we will draft a definition for that part in particular, because there was not a national one available.
Okay, so that sounds like something.
When would that, you mean?
Yeah.
To be included in this bill or to be included in the rules?
What's the
Like
committee's
to
will?
be done now or to be?
Yeah,
deferred? That's the question, yes.
Right. Do you want this to be part of this bill? If so, seems like we would have to table and take this up again to give you a chance to get us that language so we could look at it. Or again, as Colleen suggested, you could put it in your rules.
Or you could vote to include it. I could work with them and bring it back to a language review. That's
Yeah.
another question, the definition. Yeah.
I would feel like that may be the most efficient of the options, if that is a possibility.
Yeah, I don't know if the committee would be comfortable voting without seeing that language. So,
Okay.
yeah.
Yeah, I definitely want to see that language. The thing I heard about EMS, becoming an EMS professional is it was really hard to get an instructor in rural areas. So I'd really like to see what your definition is of an instructor. Yeah, that's really important to me.
not to belabor the point, but one of the reasons that we identified that it was so important is because when we define something, we don't want to inadvertently exclude some folks that we know already add tremendous value. And so I was thinking of our small communities that have some folks who are transient for a month or two that come in and teach very specific subjects, but they're experts and they're obviously qualified. We're not looking to require them to license to do that. But for folks that consistently provide content and hold themselves up as this is a person who licensed you to do this job, we absolutely want those persons to be regulated and held to standard. So that was how that worked.
Okay. Anything else? Representative Foley.
Okay. Colleen, I just want to make sure that, so if we adopt the amendment, that it will get rid of the fiscal note.
It will. That's my understanding from speaking with Mr. Monteo. Yes.
So will it have to go back through and then come back to us
It will.
to show
Yeah, you'll get a
zero?
revised fiscal. Yep. And they'll look at the whole new amendment, but yeah, hopefully nothing else in the amendment will trigger fiscal. Yeah.
Anything else? Looks like we're probably going to table and come back to see that language, but anything else that you would want in the interim? Okay, then I'd entertain a motion. Representative Matheson.
Make a motion to table.
And is there a second? Seconded by Representative Arford. All those in favor? Right, so it's unanimous. Thank you. We'll close the work session on LD 2133. And I think Colleen, you have some language review for us. It isn't, it seems dark, doesn't it? But it's only, yeah.
was afraid it was much later.
Yeah. I don't think it was very sunny today.
So Ed is gonna pass around their paper clips together. You've seen the orange ones before, so I don't think really we're just causing it like that, but. Thank you.
Thank you.
There's only two that are divided, but the first one is divided. And those are extras on the end, and you should have a paper clipped version for yourself to keep, so. You ready for me to go start going
Yes.
through? Okay. So the first one on the top is LD 1901. This is the bill to regulate shared appreciation agreements. And you'll remember there are two amendments, and the split of the committee was how to address sort of the how to address the regulation of shared appreciation agreement. The majority report voted to put a moratorium on shared appreciation agreements until January 1 of 2030. So that's the first page of the yellow here. It simply would prohibit a person from entering into a shared appreciation mortgage loan with a consumer that's secured by a dwelling in the state. It says that any shared appreciation mortgage loan entered into in violation of this section is void and unenforceable. It defines both a dwelling. There's an existing definition of what a dwelling is in the Consumer Credit Code, and defines a shared appreciation mortgage loan. The minority report, which was supported by 5 members, would put in place the suggested proposal that was put forward by the Bureau of Consumer Credit Protection and consumer advocates that would regulate shared appreciation mortgage loans like other mortgage loans. And so this language of the amendment really is the language that you saw when the committee took the vote on the proposal. It's just cleaned up and put in statutory form. It makes the appropriate changes. It defines shared appreciation loan as a consumer loan, defines a creditor to include a shared appreciation mortgage loan lender, puts in place some definitions, directs the administrator of the Consumer Credit Code to adopt specific rules related to the terms of the loans, certain restrictions, standards for homeowner, counseling, consumer disclosures, puts in place specific definitions, and then puts in place, as I mentioned, some specific requirements for shared appreciation mortgage loans that are found in section 8 of the proposal, which are found on pages 8, 9, and 10 and 11 of the proposed amendment. And as I said, all of this language was in front of the committee when you took the vote. I've just cleaned it up. What the committee's amendment did choose to do for those members supporting this proposal would put in place which is new language in section 10 that's starting at the bottom of page 12 and the top of page 13 would require that the superintendent of consumer credit protection report back to the committee no later than February 1 of 2029 on their findings and recommendations regarding the regulation of shared appreciation mortgage loans pursuant to these provisions, and then would give the committee the authority to submit legislation related to the report to the 131st legislature. It says legislation, which means more than one bill. If you want to limit it, you could say a bill, you could limit it to a bill. But it would provide an opportunity similar to the moratorium for additional legislative action to be taken at that time. So that's the minority amendment, and you'll see everybody's votes on the very last page.
I just had, oh, go ahead, Representative Mastraki.
You can go first if you want. I was just going to refer to a letter that we received.
I was too, so go
Oh,
ahead.
then you go ahead. You're the lawyer.
I wasn't going to refer to the letter, but I was just going to indicate that yes, we did receive information that these are being marketed. And so my question for clarification, and maybe Ms. Conti can help us here, is, no matter what happens, ultimately, what are going to be the consequences if some of these are entered into in the interim? I mean, I see what happens if one of these passes, but in the interim, what can we do?
Between now and.
Yes,
Well, we do have the advisory ruling.
I know, and I don't remember the
I-
consequences in the
Yeah.
advisory ruling.
Yeah,
In particular, does it make the mortgage void?
that's the question. I mean, under the advisory ruling, the Bureau has taken the position that they are mortgage loans.
Right. I understand that. I just.
But the extent to which
and
they
it-
can enforce that, it's an advisory ruling is the question. of the day.
Exactly.
Well, we could sue them. We
I
could sue them
understand
and say,
that.
you've.
Right, but I understand that, but I'm worried about the consumer. And the consumer being able to void the mortgage.
I don't know if that would, the consumer would also have the right to sue them, after the fact and say, this wasn't made in my best interest and you took advantage of me and I shouldn't have made this loan. And then if the court found for the consumer, I don't know what remedies I'm assuming a court would have a large number of remedies at its disposal, including undoing the deal. But the consumer would have to prove his case that he was,
So I guess the question, Colleen, is under either of these reports, can we make them retroactive?
Retroactivity is always tricky.
I know.
You can try. I mean, you can add a retroactivity provision. But I don't know what the date, retroactive to when. You have to be specific about the date, right? But you can add a retroactivity provision. Whether or not that's
I mean, I'm trying to come up with
work.
what's the way to
Yeah.
make it clear that,
Right.
if some of these are entered into before, whichever version goes
Right.
into effect,
Right.
that those can be easily voided. That's what I'm trying to come up with. Representative Arford.
Thank you, Madam Chair. So I wasn't here for the vote. I voted after the fact because I was testifying in another committee. And was there a reason we didn't put or at least attempt to put an emergency on this?
I believe because it was
It's
divided.
divided now. If you were unanimous, you could. That would be one way to get it faster.
Sure.
So in order to put an emergency on a bill, again, I'm not sure of this, you have to have a unanimous report?
No, you have to have a 2/3 vote of the House and Senate. And so if it's divided here, then it's usually a clue that it won't have the 2/3 over there. That's all.
Yeah, no, but I would actually be willing to change my vote if we, because it seems like this, I mean, this could be a serious situation evolving, and if this doesn't go into effect till next summer at the earliest, then some damage could be done that we might be able to prevent by doing this as an emergency. So I don't know if there's any process, path forward to do that, but I would be willing to change my vote to prevent that.
Representative Matheson.
I would be very willing to have the committee reconsider this and go with the amended regulation, considering we're having difficulties already. I would consider that a real good move on the committee's part.
I didn't understand what you meant.
I'm happy to reconsider this, revote it, and move it forward with the amendment that I voted for. So I'm happy to reconsider it, but I don't think that putting an emergency measure on it is going to help at this point in time.
Don't understand that, but Representative Foley.
I mean, I would be happy for us to revisit it. I just don't know why we just wouldn't go with this, the moratorium period, and just put these things to bed until 2030. I don't.
I think the concern that we had is coming true, which is not all the players are the ones who indicated, in good faith that they weren't going to do this and that they weren't going to challenge a moratorium. A moratorium is easier to challenge than a regulation, right? So knowing now that someone is actually marketing them, I think that's the concern from my end with doing a moratorium, is that I think it's more open to challenge when you say you can't do anything, as opposed to, oh, you can do it, but we're going to regulate it.
Yep.
So Representative Mastracchio.
Thank you, Madam Chair. So I'll reconsider, but I would like to amend what I voted for, which was the regulations, and include the provision that says that any HEI loan made in Maine through Mortgage Help Center or by Home Tap or any other HEI lender would be void and unenforceable. I mean, I think that I kind of want to make sure that they're not going to sneak in there and do something that the homeowner shouldn't have to sue. It just costs them more money. We know this is bad. I just want to figure out how to make them not do it.
My only suggestion, and I don't know if it's helpful, is maybe you could include some language, some unallocated language, making the codifying the advisory ruling back to the date that the advisory ruling was put in place.
Oh,
You know what I
you're
mean?
So
it's
good.
not retroactive, but it's like the advisory ruling, you know what I mean? As of the date of the making that statutory, but putting that in place up until the point of like this becomes effective. You know what I mean? I don't know if that
Right,
works.
so that we're clear that
So
at
that
least the advisory
At least
ruling,
from that date on,
the advisory.
these are
ruling-
mortgage loans, right? These
Yes.
were mortgage loans for anything entered into prior to the effective date of this bill, back to the date of the advisory ruling. It's considered a consumer loan, and then this would be in place for
And
things
could
moving
we
forward.
say, and
I
they're,
don't-
and they're void and
Yeah, I mean,
unenforceable?
I don't know if we could try it, but that's my only
Yeah.
creative suggestion, perhaps.
Well, yeah, that sounds a little more defensible than
Then a
just
retroactive, just a straight retroactive, right? Because I don't know what you'd be retroactive to. At least it gives you a date and like an affirmative kind of regulatory decision.
Yes, yep, Representative Boyer.
Thank you, Madam Chair. Colleen, I thought on the minority report that there was a sunset, but I don't see that.
The sunset is sort of the report. It's
The
not really a
report.
sunset, but it's a report back that then would give the legislature at that time to take action to decide if this is enough or if they need to, what needs to be done. But those were the differences in the approach. The first one was sort of a sunset. The majority was a clear sunset. And the minority, as I understood it, was not a sunset, but a report back that would then prompt the legislature to take some action based on the activities that have happened up until that point with regard to share appreciation.
Okay, I misunderstood that because I thought this one had a sunset as well.
No. Representative Arford?
Yeah. So if we pass this, the way that it was just suggested, when the bill goes into effect, everything that was done after that point in time when this rule was adopted, then they will be null and void. Of course, it probably be challenged in court, but everybody's thinking now that it will withstand a court challenge. Is that what basically was you just said?
We just said it was more likely than a straight, just let's make this retroactive. It's more defensible, in my opinion.
And we also have to run the risk with the ban of that being challenged in court now. We're thinking even more likely with the nature of the actions that are being taken now that we did not think would happen now, and they are.
In
So
my opinion,
whichever direction we go in, we're running a potential risk
yeah.
of a court challenge.
Sure.
So what I would like to see happen, and maybe this is not at all possible, but I do believe it's in the best interest of the people of Maine, if we rally around going back to the original date, enough of us to put an emergency on this and pass it, see if we can get it through. We can always whip the emergency off on the floor if it doesn't look like it's going to go anywhere and we won't be any worse for wear. But if we put an emergency on it and it actually flies, then it will go into effect immediately. So the amount of time that passes, that people could actually purchase these and that there'd be more risk of a court challenge. It will just really reduce the risk of that. So I do think that if I'd be willing to change my vote for sure. I mean, if this had an emergency on it, it would be a much stronger bill, I think.
Sure. Representative Matheson.
So I guess I
Oh, but
just,
that's my vote. I'm not changing my vote. I'll stick with
yeah,
it.
I didn't think you were, but thank you
sorry.
for that clarification. I guess I would just pose the question to the committee. The reason we all had said on mic that this is not a good product and we wanted to make sure that consumers are protected. It seemed like from my standpoint that we went with the moratorium because we assumed that people were going to not offer this product. I guess my question to the committee is why are we continuing to go down the moratorium and not regulating this from the very beginning? I don't understand why we're pushing for that when we actually all think that this product is not a great product and we care about our consumers. That really is an honest question to the committee.
Representative Foley.
Colleen, your suggestion, with the advisory ruling, are you suggesting that we put that in statute?
Yeah, it would be like unallocated language or something, yeah.
So you would keep the minority report as is
And then
and
add it
insert this in there.
To cover the.
gap period.
From the date of the advisory ruling
So when it becomes
to
effective.
whenever it becomes law. And also add to the language of the advisory ruling that a violation
Yeah.
would mean that the mortgage is void and unenforceable.
That was my suggestion, to try to address the gap period.
The gap period.
It would give a little more teeth to the advisory ruling, which is in place now, or try to.
Yes.
So I hate to sound, I don't understand, but why do we think, or why would it be that adopting the language with the bill language, why is that more enforceable than the moratorium? Just only because we put it in statute?
No, they both would be in statute. I think the thinking is that the moratorium is an attempt to prohibit someone from entering into a contract between two parties,
And I think there's an argument.
Yeah.
That it violates the
Right.
Commerce Clause.
And so
of
that's,
the
that's,
Constitution.
that would be a constitutional like issue that they could raise because it's prohibiting two parties from entering into a contract. And the second version, the minority report, regulates these and says you can enter into these contracts. It's not saying you can't, but it says you can, but you have to follow these provisions. And those typically have been upheld against or can't have more of a chance of withstanding a challenge on those grounds, I think. So I think that's the thinking about the difference between a straight out moratorium. You just can't contract in this way versus you can do something within the parameters of the statute. Does that make sense?
Historically, the courts will uphold the state's right to regulate. I'm talking very
Just generally,
broadly,
yeah.
generally speaking, okay? Because before everyone sends me all the cases where they didn't, don't. I understand. Just generally
Very big
speaking,
picture.
yeah. So Representative Flynn.
Thank you, Madam Chair. I don't see this product as even remotely needed in the state of Maine. I don't see any credit crunch that where people aren't getting access to capital, debt capital if they need it. It's there. This particular product will prey upon people that have large land holdings, probably have held it for many, many years. In rural areas, there's going to be people with 200-300 acres of land. That's going to take advantage of their appreciation and the value of that. Home equity financing has been in place for about 30 to 40 years now. It seems to have addressed all the capital needs for individual credit. I don't see the need for this product, thus the moratorium. I don't know how they ended up here in the first place. But I see them as an organization that they're doing their homework. They're running their algorithms. They're knowing who these people are and they're targeting. And I don't like it in rural Maine. And for that reason, I'm saying let's cease and desist. If we find later on there's a need for credit products, for consumer credit product, it could be looked into, but I'm not seeing any need for it right now. So I don't think we need it at all.
And just to be clear, I think we all agree on that.
Just how we
We're just disagree on the best way to do that effectively. So just to be clear, the minority report is not saying we need this product. The minority report is saying we are going to regulate it such that we don't think they will be able to offer the product.
And then I'd like to, once we're done, I'd like to comment.
Sure. Representative Mastracchio.
Thank you, Madam Chair. And to be clear, it is really about adding that other piece in there too, the unal, and
The gap
that
period,
says,
yes.
oh, by the way, and if you go ahead and do it, it's not going to be anything that's enforceable. I just want to make sure that the person who's already in trouble, or they wouldn't even be looking at these loans, isn't going to be in a position where they're going to end up having to spend more money or they're going to lose their house. Let's just face it. That's what this is going to be about. So I want to do it. I don't want it to be in court. I don't want the court to say, oh, wait, the law is going to sit there for a while because, you know, it's unconstitutional for you to do that. That was always my concern. I mean, I would love to be able to ban them, but I've learned that when we did a lot of work in Sanford I remember when methadone clinics and there were people just ban them. No, you have to regulate them because you can't do that because they were going to take us to court. And so we regulated them and it worked out really well. It solved the problem. We had methadone clinics, it treated people, but it didn't impact in the way that it could have if we had totally said we didn't want to have them. So I'm just hoping that we can come to agreement here because I do think we need an emergency on it.
I agree. There's someone down here, Representative Boyer, sorry.
Thank you, Madam Chair. I just keep raising my hand.
I just keep looking that
Christy
way.
No, I had a question. I think it's for you, Colleen, but maybe for Superintendent Conti. So the industry is going to continue to be innovative and come up with other things. So the minority report, like if we just call these something different, then do we have to, I guess what I'm thinking, and maybe this is too far down the road, but like when something else comes up, is this going to regulate that as well just under a different name, you know, so instead of a shared appreciation mortgage loan, maybe now it's called, you know, I don't know, investment mortgage package.
I mean, I think the definition, the description of what it is tries to get at, you know, statute can call it whatever, you know, can name it whatever, but the description of what it is trying to encompass like other types of, all the types of arrangements, I think.
Okay.
And so that would, even if it's called something different, if the superintendent looks at it and looks at how Maine has said, you know, defined what a shared appreciation mortgage loan is, even if they call it home equity investment or something. But she looks at the definition here and it says, well, that meets the definition, that they can regulate it. Okay, that's my take.
Okay, yeah, thank you.
Not to say it wouldn't get everything, and there might be a reason to come back, but it's attempting to be a broad enough definition to capture a number of different types of products.
Yeah.
Did you want to say something?
Yeah, I would say my only experience with moratoria was when I was on the planning board. And usually what they do is they say, oh, someone's gonna want to build a Walmart in town. We want to put a moratorium in place until we can put the zoning rules in place to address that being constructed. So it would be like, if you want to do a moratorium, it should be like for a time certain until you have time to put in place legislation. It shouldn't, I'm worried about it just being an open-ended moratorium forever. You know, usually they're tied to a reason. Like the reason is because we need to study this, or we need to get a report back on this, or whatever. Just on making it,
Usually that's 180 days.
Well, yeah, that's
Yeah,
by state law.
has to,
Yeah.
right.
Yeah. Can only
So
do
that's-
that. Okay. Did you want to caucus?
Yes, please.
Okay. So we'll break for approximately 10 minutes or so for people to caucus. All right, we're gonna pull up the gavel again. Okay, so we're back after taken a brief recess to caucus with folks. And it sounds like there's a consensus to reconsider. Would someone like to make a vote? Anne Marie?
I'm just.
Yes. Representative Foley.
I'll make a motion that we reconsider our actions on LD 1901.
Is there a seconded by Representative Mastracchio? So all those in favor of reconsideration?
I'm sorry.
And that is unanimous. All right, and so now we're reconsidering. Would someone like to make a motion? Representative Matheson.
I make a motion to pass as amended, including the amendment that Superintendent Conti suggested about advisory. Thank you. I knew there was a word that I was missing there.
And adding an emergency.
And adding an emergency.
And then
Go ahead.
are we,
Minority report.
Yep.
Yes.
Plus adding an emergency, plus codifying the advisory ruling back to the date the advisory ruling was issued that we're talking about.
Correct. And adding the void
Void
and
and
unenforceable.
Yep. Okay, I got it. Thank you.
I will second that. Discussion. Representative Foley.
so would we put in there a retroactive date, or just the fact that we're referencing this advisory brings it back to that?
It would be, we'd go back to the date that the advisory ruling was issued. So whatever the date on that.
October
June.
29th,
Oh, yeah, whatever it is.
2025.
Yeah, that would be the date. to Go back to.
Further discussion? Okay, and are you caught up? You're so good.
Senator Bailey?
Yes.
Senator Bailey, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Alford?
Yes,
Representative
please.
Alford, yes. Representative Boyer?
Yes.
Representative Boyer, yes. Representative Clucci?
Yes.
Representative Clucci, yes. Representative Flynn?
No.
Representative Flynn, no. Representative Foley?
Yes.
Representative Foley, yes. Representative Mastracchio?
Yes.
Representative Mastracchio, yes. Representative Morris?
No.
Representative Morris, no. Representative Olson?
Yes.
Representative Olson, yes. 8 members of the committee having voted in the affirmative and 2 in the negative.
Your minority report.
Yep, minority report is the
Majority
yep,
report. Yeah.
The
The previous
old report.
majority
Right,
report.
exactly.
Yeah.
Now the minority.
Okay.
And that's
The
for both,
moratorium.
that's for both of you, Representative
Yeah.
Flynn. Yeah, okay, thank you.
Okay, great.
Want to confirm that? Okay.
Thank you.
It did, I know.
It'll come back again.
Yes, it will.
Another language. Thank you. Another opportunity to reconsider. Okay. So I think the rest of these will go a little quicker. But the next one is LD 2005. Actually, you saw this prior language when the committee took the vote on this bill. This was LD 2005. The italicized language makes the clarification that was voted on by the committee that if the mail delivery is delayed by more than 1 day, the person's entitled to no more than a 7-day supply or the smallest prepackaged unit of dose of the prescription drug. It also clarifies that a covered person may not be subject to more than one copayment, coinsurance, or other out-of-pocket payment for the dispensing of the same drug in these circumstances. That was unanimous, ought to pass as amended. The second one is LD 2061. This clarified the provisions related to the definition of a billing statement, making it clear that it means a periodic statement as well as a monthly statement. It applies to statements that a person is required to provide pursuant to federal or state law. Does not prohibit the charging of a reasonable fee as long as the fee is fully disclosed to and authorized by the consumer prior to the copies being provided. This was unanimous, also adds an emergency preamble and an emergency clause as voted on by the committee. The next one is LD 2074. This was the department bill related to social worker licensing. It adds an emergency preamble and an emergency clause, and also adds an unallocated section to the bill directing OPOR, after consulting with the Board of Social Work Licensure and stakeholders, to continue review of the licensing chapter, any laws associated with the provisions of that chapter, recommend changes to update the licensure provisions for the social work profession, including changes to the educational and examination requirements for initial licensure, consultation requirements, and to recommend alternative pathways for licensure. The review should look at best practices in other states, report back to this committee next year, and it gives the authority to report out a bill to the 133rd legislature in 2027.
That's the Boyer Amendment.
Right. A bill. That's right. That's 2074. The next one is 2087. This was the department bill related to sign language interpreters. It adds an emergency preamble and emergency clause, and then clarifies the provision related to emergencies to clarify that the determination of an emergency may be made by the department at any time. So it just adds the definition of an emergency as determination by the director that a serious, unexpected, and potentially dangerous situation is occurring or did occur that requires an immediate need for interpreting services. So that, I think, clarifies that. Puts on the emergency. The next one is LD 2102. This was a divided report. It's 12-to-1 report. This is the loan guarantee program.
That's the one.
Oh, gee.
Bill. This puts in a provision that modifies the maximum amount of the loan to say that unless an origination fee is included and added to the loan amount, the maximum amount of the loan is the lesser of 6,000, or the amount borrowed.
Wait.
Can you say that again?
Yeah. Say that again.
So the committee, I go back and start from the beginning. So it's section 3 of the amendment. You had decided to add an authorization that would allow an origination fee to be charged not to exceed the lesser of $60 or 1% of the loan amount. And if an origination fee is included, you would want it to require the eligible financial institution to add the origination fee to the loan amount.
Thank you.
Yes.
The statutory provision in the existing law in section 2 says the maximum amount of the loan is $6,000. But if you're going to add an origination fee,
Got
it's going to be more than that. So that's just saying that accounting for the addition of the origination fee, if there is one. You're not saying it has to have an origination fee, but if it does, you can add that to the maximum. Section 4, instead of repealing the provision that related to terminating loan guarantees based on excess claims, you increase that percentage from 10% to 50%. Section 5 adds a notification requirement. So it requires the authority, FAME, to immediately notify the treasurer and the legislature if the total amount of funds expended for loan guarantee payments equal or exceeds $200,000. So if it gets, around $50,000, I think was what Mr. Norbert had suggested. And then it also changes the the authority to report out legislation from a may to a shall after receiving notification that there's some funding needs.
Okay.
That the funding is less.
Great.
So this is the majority report of the committee on that. And then finally, these last 3, the committee has seen these before. You hadn't seen the fiscal notes. No fiscal impact, minor fiscal impact. No fiscal impact for 2 of them, minor costs for the 3rd. So nothing new other than the fiscal. The
All
last 3.
right, we like those.
Thank you.
All right. Anything else?
I didn't have anything else.
Okay.
You are meeting next Tuesday and Wednesday.
Yes.
Yeah, we just went through that.
Yes, and I guess please let us know if you're not going to be here. We already know Representative Clucci and Representative Foley are going to be participating by Zoom. So it's going to be real important that we all show up so we have quorum in person. Representative Mastracchio.
Tuesday at 10.
Yes.
Okay, just want to make sure.
Yes.
Yes, nice. Thank you.
Yes. Yes.
Although I did try being the most on time.